the key issues of the day, and that is maternity. And maternity will indeed form an important theme throughout our board this morning. So I'm going to hand over to Fiona and colleagues to introduce the patient's story, which today will be focused on maternity. Fiona.
Thank you, Simon. Good morning, everyone. My name's Fiona, and as Director of Nursing, I'd like to introduce you to James, who's our Head of Patient Experience, who has kindly pulled together the story for this morning, which, as Simon has commented, reflects some of the discussion that we will be occurring later in the board, focusing on our maternity services. Thank you, James.
Thank you. So my name is James. I'm the Head of Patient Experience and Involvement here at Kettering, as said by Fiona. With the publication of the Ockenden report, and that being the theme of today's meeting, we have a maternity-related story to share. Today's patient story is from a lady called Katie, who had a planned home birth in October 2020. All was going well with the delivery and things were progressing. But unfortunately, she had 2 obstetric emergencies. You'll hear about the swift action from the team, the coordination of both Katie and her baby's care, and the good communication that took place. I've had the pleasure of talking to Katie about her experience and was blown away about how positive she was, given the difficulties that you'll hear about. And I'm also pleased to mention that I'm joined by Amy, who is the maternity matron, and you'll hear more from Amy a bit later in the video too. With all of these stories that we share, it's always more powerful coming from those that are involved. And with that, I'd like to hand over to IT for them to play the video for you.
Midwives deal with obstetric emergencies every day. We're trained to be able to act efficiently with guidance and support women through these difficult experiences. We're also trained to look after and care for women who choose for a home confinement, and in Katie's case was opting for a low risk home delivery. We facilitated that spectacularly. What we hadn't anticipated, which in obstetrics and midwifery we can't contend with, is unforeseen emergencies such as Katie's. In Katie's case, once her labour progressed and it was deemed that baby was in a breech position, so baby was being delivered feet first, again, the community staff acted very, very swiftly. In Katie's case, we then had a second consecutive obstetric emergency, which put baby into a significant compromising position because a loop of cord came through, which could, in essence, starve baby of oxygen. What the staff who were working with Katie at the time were able to do absolutely spectacularly was keep her calm and reassure her through this. And obviously a traumatic experience for both mum and the staff at the time. The team contacted straight through to the ambulance on one phone and the delivery suite coordinator who leads from the Kettering delivery suite. It just so happened that we had the obstetric consultant on call as well, very close by. So a really great effort from a multidisciplinary approach, having that communication over the phone, so that the community midwife was able to provide absolutely spectacular care to optimise the safe delivery of baby. Once those phone calls came through, what the staff inside the hospital were doing, which again, probably unbeknown to Katie and her family at the time, was that we were working seamlessly with the LNU staff, so the neonatal nurses and paediatricians, so that we could anticipate a potential poor outcome of this baby. The coordinator also ensured that the room was ready for Katie's arrival, so that we would anticipate that Katie would want to be with her son immediately on arrival. And so this was supported really, really well behind the scenes. Unfortunately for Katie, the first ambulance that came obviously had to prioritise her poorly son, who had to be taken away from Katie moments after his life. And Katie did not know at the time that he was well and hadn't heard him cry. He was being actively resuscitated next to her following a delivery. She didn't know whether or not he had a heart rate and how well he was going to be. On arrival to the hospital, the LNU staff were waiting for him and provided that immediate care that he required, and took him into the LNU unit, where they continued to care for him really, really well. Katie arrived shortly after, but in that time, again, the midwives thinking at home, how can we facilitate seamlessly providing care? So continued to do absolutely everything for Katie whilst we were waiting for that ambulance, and time was ticking to try and get Katie's mind off it, and completed her suturing and made sure that as soon as she was arriving at Kettering, there was no delay in getting mum and baby back together. Baby did receive resuscitation in the ambulance by the community midwife, and was able to provide a strong heartbeat or hear a heartbeat during the resuscitation. And on arrival, baby was in a better condition, which was great to know. As soon as Katie came in, we were able to relay that really, really important message to her. As a manager on call on that day, on a Saturday, I remember getting the call, and again, nobody knew how well baby was going to be. So myself and one of the other matrons knew that we would need to do some support immediately, so came in myself to primarily speak to Katie and support in a way to protect her well-being and make sure all of the information was available to her, still not knowing how baby was myself. And one of my colleagues came in to support the staff that were involved in this truly traumatic experience. Once I attended the hospital and we knew that baby was well, and Katie was round with him, a little bit of time passed, and I went to go and see her, and she was such a happy mum, and her partner was there as well. It was a great experience to be able to see that we had been able to provide such a holistic approach to this family in what could have been the darkest hours of their lives. What was lovely to see is, I had the opportunity to speak to her and debrief to a level that she felt that she needed at the time, but also information was given to her that she could contact us at any time. The LNU staff were amazing at being able to provide immediate care that Katie had missed in those precious moments. And from a conversation later on down the line, Katie was really grateful for that, and that bonding was able to be achieved, albeit shortly after, knowing that baby was well.
I don't think there's any much more I could add to that story, but we'll be happy to take any questions if you have them.
I'm just checking that Alan is back with us before I
Yes, I am. Just yes, thank you. I did hear it. Anyway, yes, a very impressive report by a very impressive midwife, if I might say so. Any comments or thoughts at all on that? just Simon. Simon.
So, Alan, I was wondering, because you were having your IT difficulties, whether we could give the floor over to, in actual fact, Amy, who was seen on that video. I know you can't put your camera on, Amy, but welcome. And just to start with, wanted to say thank you for the extraordinary care that you and the team provided to Katie, and it was so good to see the outcome. But we're here today, Amy, in part to talk about Ockenden. And I just wondered whether you wanted to share any reflections you had on that case, and in particular, if there's anything as a board we can do to support you. But I felt it was important you had the opportunity to say something. If you're there and able to speak.
I am. Thank you. Yes, sorry about the camera issue, but obviously you've seen my face quite loud and clear. Yeah, I think it's an absolutely moving story, and I was really grateful that I was able to work with James to give you all the opportunity to see what great care that we can provide. It's absolutely clear that in the NHS today, you know, we are in a situation where staffing is always at the forefront, but even during all of those you know, difficulties, we can still provide seamless multidisciplinary care. I think just remembering Katie myself, it just so happened that this lady could not fault any aspect of her care, where we've had similar situations where sometimes just even one negative can impact the whole story. She just turned everything. I mean, ultimately what I'm trying to say is this boils down to such an amazing lady, to be able to take on such an experience. I don't feel that I was necessarily part of the care, all of that amazing work that the community team did. There was not one person in that care. It was such a team effort. So I'm just really proud to work with our team.
Okay, thank you very much. Paula, although I suspect you're being a bit unduly modest, but anyway, Paula, and then Rabia, and then Andy, and then Debbie, in that order, please.
Thank you, Alan, and thank you, Amy. It was a really lovely video. I was very interested to hear that you had a colleague come in specifically to support the staff who I'm sure were deeply affected by what they were doing that day. Can you just talk to us a little bit about how you support staff in those situations?
Yes, of course. I mean, my role myself, I'm the inpatient matron, but Kath Betts, who is our community matron, we work closely together, and unfortunately within maternity we do have incidents where things can affect us quite significantly, and both myself and Kath had said that if at any point during our while we're on call or not, that we feel that we can support staff in any way. I suppose because we've had incidents in the past where it's not necessarily just a mum, it's a baby as well. We just want to be able to be, to debrief immediately and just anticipate what is required from parents at the time. We want to make sure that we're able to support. Kath herself is a midwifery advocate, so we can just signpost early on to wellbeing support groups, as well as anticipating if any other staff need any amendments to their to the rest of the day, because I think ultimately the difficulty we have here is that we wouldn't want to put anyone in a position where there's unsafe practice for other women at the time. So we do try and support in a multitude of ways. I hope that's answered your question, sorry.
Yeah, no, it has. Thank you very much.
Rabia.
Thank you very much, Amy. I'm sitting here actually with a bit of goosebumps, because being an obstetrician and cord prolapse, a life-threatening emergency, even in the hospital, is actually, you would agree, Amy, is something which actually really makes all us clinicians anxious. Doing it so well from home And when we are talking time-wise, we're literally talking get it right in the first 4 minutes. So I just wanted to share that with you, that absolutely felt every word you were saying there. But in my view, I think what got it absolutely right was the compassionate leadership, Amy, including yours. You've been very modest there. The compassionate leadership, teamwork, and culture. It was so visible from your story that actually the integrated working throughout, from hospital to home to back to hospital, it just works seamlessly as one team. And I think that's what Ockenden actually identified as the biggest gap.
Yeah, I mean, in the video, how much do I press that this baby was significantly compromised? Yeah, I think every single member of the staff that even had any aspect of this care was really concerned about this baby, plans were being told over the phone really concisely. We were having scribes, sitting down. We had the phones on speakerphone, so we could really, that's one thing I have to say maternity do really well with. Records are absolutely spectacular, but yeah, I mean, this baby, and to say that Katie just didn't know, she left her baby not knowing. I do feel what Katie, and that's where I really treasure what Katie was saying, is that some people wouldn't realize what was going on behind the scenes, and she got it. She realized as soon as I saw her, she said, I couldn't have come and seen my baby any quicker. And everything that we did, she hit the nail on the head. She knew what extra efforts had been put in, and just because we all knew that her priority would have been her son. So yeah, thank you for that, Rabia.
Andy.
Thanks, and how brilliant to see, such a happy outcome of this arrangement. I just wondered what support is available to the family ongoing. This has touched a nerve with me. We had quite a traumatic birth with one of my children, and I got to say the experience took several years actually before I would not burst into tears in thinking about it, and it wasn't as traumatic as the one described. I just wondered what support is available to families sort of on an ongoing basis.
Yeah, so I was involved in Katie's case further along the line as well. We have a perinatal mental health midwife, and we were able to provide all of those contact details to Katie. She will have been in contact with her further than the 28 days that maternity naturally look after our patients. It just so happens in her records she has had contact with those teams that can extend the support. Again, for Katie as well, what was really clear is that she wanted to know that support would be put in place for any future pregnancies as well, knowing that this, although she was singing our praises, to say the least, that traumatic experience would potentially trigger for a future pregnancy. So we have got that in place. So she has had that contact details from the perinatal mental health. And like I said before, my colleague Kath Betts is a midwifery advocate, and she was able to do a later debrief around 6 weeks.
That's fantastic. Thank you.
Finally, Debbie.
Yes, thank you, Chair. Thanks, Amy, for doing this and sharing the story, and obviously thank you to Katie as well. It certainly brought a lump to my throat at times. So a key part of Ockenden is absolutely about listening to families, and I can see that we have done that here, and certainly through the questions as well. So really good to hear about a good experience and a good outcome, and sometimes it's not just about learning from incidents, it's also learning from the times when it goes really well. But I think the thing that I really wanted to just home in on here was that it just shows how we've got professionals working across the community and the trust working together to care for our mums and babies in what can often be quite a challenging position, especially out in the community. So thank you to Amy and Katie, but also I must say thank you to our EMAS colleagues who also played quite an important part in this as well. Thank you, Chair.
Thank you. Okay, no other comments. Well, I think at the end of that, Amy, we've all ended up being very impressed with what happens in our maternity services, particularly in a crisis. And you've been a very, very effective and powerful advocate for that this morning. We'll be talking about Ockenden later on, and I have some notes from our non-exec director who looks after that, Dr. Llewellyn, which is very supportive of the work that the department has done on Ockenden. And I wish you good luck in the rest of your career, and I thank you for that video and for the leadership you provided. Thank you very much, Amy.
Thank you so much. Thank you. Bye.
Bye. Okay, on the assumption you haven't done welcomes, apologies and declarations of interest, we have apologies from Mark Smith, which is why Paula is here, Lisa Llewellyn, Chris Welsh, Trevor Shipman, and we're welcoming sometime during the morning Karen Spellman, Dr. Bilalika, who will be doing his annual report on junior doctor hours, and Kim Atley supporting the agenda items today. We've done the patient story. Is there any comments now Amy has left? Anybody wants to make it on? No? Okay, thank you. No. Minutes of the previous meeting held on the 31st of March. Are you happy to refer record? Yep, good. And the action log? No, okay, I'm happy. Well, congratulations to Faye for her permanent appointment into the role. She can take down the interim from her title board now. and also congratulations to Becky Taylor, who's been appointed as our Director of Transformation. I'm sure both of you will do very well as KGH Chief Operating Officer and as I say, Group Director of Transformation and QI. We are advertising for a new non-exec director to replace Janet, and I've said to you before that we're not making any great changes to the structure and use of non-execs. In fact, we're looking for another Janet, which is quite a hard thing to find. Closing date for that is the 30th of May, and we have a very good early indications of candidates. I've spoken to quite a few of them, and we're pretty pleased with where we are so far. Sorry. And the final thing is really, I mean, this sounds slightly peripheral, but it isn't. It's very central to what we do, is the Leicester University research ref score, where they've leapt up 23 places to be second equal in the country. The research, that's the research quality research score, research evaluation. And to be second only behind Cambridge is quite remarkable. Second equal, to be fair, I'm sure Edmund would say with UCL, but second behind Cambridge, ahead of Oxford, Manchester, Birmingham, Nottingham, King's, etc., etc. Is quite, and sadly Edinburgh, it's quite a remarkable achievement for the university. And it sounds, as I say, you can think that's a little bit peripheral, but in terms of our linkage with them and the quality of associate professors that will allow us to recruit, and the quality of the research funding that will flow from that. And this was all through the clinical school. Edmund's colleague, Andre Nig, is his equal, is his opposite number on the NGH board. And Andre is a cardiologist. So Andre went out of his way to point out that fully 50% of the research score had been, or the research submitted to the evaluation was coming from the cardiorespiratory function, which is also particularly good news for Kettering, given that that's where the Centre of Excellence for Cardiology is going to be, and all of which points to the opportunity for a significant improvement in the quality of what we do, led by research and clinical academic leadership. And those ref scores last for, I think I'm right, Edmund, in saying 7 years. So that's a long-term opportunity to build on a score that anybody involved in academic medicine or in research pays an awful lot of attention to. Edmund, would you like to blow your own trumpet on that?
Yeah, well, no, thanks for that, for the opportunity, Alan. We're absolutely delighted with our REF results across the entire university. As you say, we went up by 23 places, the top 30 university. Second in clinical medicine. We're very, very proud of that. And as you say, Alan, it provides a foundation of real excellence to enable our partnership and our engagement to flourish. So really delighted. Thanks for highlighting it. I think it demonstrates the strengths of the university, and it's going to underpin the strength of our ongoing partnership.
Thank you, Edmund. And finally, just a quick thank you to all the staff and the teams who worked on the FOGS issue and resulted in the second CQC inspection, which thankfully and justifiably was significantly better, and the problems had very largely been resolved. So many thanks to the quality committee for overseeing that, but more importantly for the staff. Debbie, I'm sure you'll pass that on, and Fiona, to the staff who were involved in all that work. Simon.
Thanks, Alan. Morning, everybody. So I thought, as we are now in a new financial year, I would synthesise for the board some of the messages from NHS High Command, which are contained in my report today. So the first of those is simply to record that since we last met, Easter has happened, and in actual fact, the NHS overall and our teams locally performed very well. 4-day bank holidays always put the NHS under significant strain. And I just wanted to highlight that we've got another 4-day bank holiday coming up next week. And the context of that is that Kettering's been under significant operational strain over the last few days, with very large numbers of ambulances coming in from quite distant locales. I'm sure Debbie and Faye will comment on that in their own reports in due course. So as we think about a 4-day bank holiday, I think it's important that we continue to encourage all of our communities to use the NHS safely but wisely during those 4 days, because there's no doubt that as we come back round on the 6th of June, a week on Monday, it will be tricky. Good news, unashamedly, is that COVID numbers are now at last in a sustained drop. We don't know where that's going to go in the future, but we are at last now able to start looking at taking down some of the very rigorous and measures around infection control, which have had a significant impact on our ability to get the hospital back to normal. I am confident that it is now safe to do that, and that we can, as I say in my report, pivot the hospital back towards a kind of normal mode of delivery. Thirdly, we now have a window for delivery. We start that window in a fortunate place, comparable to most other systems and indeed regions. At our QSRM, our quarterly system review meeting, which happened a week ago today, our regional director commended us on the position that we were in on all of the constitutional standards. That is not a matter for complacency, but it is a matter to cherish and to make sure that we make the best of over the next few months. But part of making the best on an ongoing basis is going to be to really push forward on our transformation agenda. And I particularly want to commend to the board the oversight and the support of the work around outpatients. That is going to be key to making the difference that we need across our planned care pathway. Fourth, money matters. We are not in a position today to sign off our system financial plan. John will talk us through the work in hand. And I just want to make the point here that it will be integral to the successful delivery of that ask, that not only do we do all that we can, but we respond as a system. We also had our hospital discharge meeting, National Hospital Discharge meeting a week ago last Monday, and again in the QSRM to counter the upside the challenge that we got in both meetings was you still have too many super-stranded patients. You still have too many stranded patients. And we know that the effect of that in monetary terms is it bakes in cost in terms of staffing that we cannot afford. So, as I say, we need to really work with health and care partners to make that different as we come out of COVID. We've often highlighted the need for digital transformation, but I particularly want to call out here the need for the system digital transformation agenda to make progress in the year ahead. Andy gave an excellent presentation to the Integrated Care Board. We will circulate those slides to non-executive directors. And it's been agreed that we will develop rapidly, as much as we can, a much more shared services model. We've had our own challenges in this space, to be sure, but what has been really revealing is that this is now an issue that the system needs to grasp if we're going to get into the place we need to. The other thing I wanted to highlight was in particular around beds and the need for us to develop virtual ward. We've had some efforts in this area, but the way in which we're going to be able to expect to care for people in the future, particularly to avoid admission, will be around virtual wards in the space of frailty and respiratory care. Turning to other issues, I've highlighted what our last Pulse survey told us, and I framed that in a much more practical sense. You'll see at the bottom of that slide that I attach in my report, pay and cost of living and inflation were mentioned over 200 times. This is now a real issue for our staff. I'm sure that I know, in fact, that we are doing a lot in this space. We have, for example, taken a decision to maintain free car parking for all of our staff for next year, and that I know was welcomed. But I raise it here today in summarising the work that Mark has done with Paula and other colleagues to ask us this question, really. Have we done all that we can? Have we really made the absolute effort to make sure that staff feel that they are supported at a very practical level to come to work? Finally, I just want to thank Debbie, Rabia and other colleagues for the very successful initiation of the cardiology workshop collaboration that was held in the last month. Our clinicians are inventive folk and they do have real ideas about what they would like to do for the future. You can see some of those there. These are their words, not mine. Dare to Dream is their idea, not mine. And I think for us, it's about how do we get behind some of those ideas and really help make their dreams a reality. Thanks.
Thank you, Simon. We'll take Debbie's report as well, and then any questions on any of them, please. Debbie.
Yeah, thank you, Chair. I'll probably start with the Cardiology Centre of Excellence. So the strategy event that we held for half a day was really well attended, actually, and the teams were really motivated to work together. I think both organisations have been in competition for so many years. I certainly weren't expecting them to come together in such a positive way straight away, but they did, and it was fantastic. And the way that somebody described it was that the teams entered as two different teams, but actually they left the session as one team. So lots of opportunities and a good future to look forward to. So in terms of discharge, thanks Simon for noting around where we are with discharge. We've been making quite a lot of changes, which I'm sure Faye will want to talk about as we go through the rest of the meeting today. And those changes have started to have an impact on the number of super-stranded and stranded patients we had in the organisation. But over the last couple of weeks, and more so over the last week, we've seen quite an increase in both A&E attenders, admissions and ambulances arriving at Kettering. We had to open additional beds this week. In our annex area of the hospital. We've now closed those, thankfully, ahead of the weekend. But I think that just shows the enormous amount of pressure that we're under as an organisation at the moment. We haven't had to open those beds throughout COVID for normal non-elective patients and throughout winter. So pressure is actually really, it's quite real, and it's there and it's in the system. But Faye will talk to us a little bit through the IGR about what we're doing about that. We did have the visit from the National Discharge Team a couple of weeks ago. They're really supportive of the actions that we're taking, actually, but quite clear that we do need better integration across the system, that we need to have a better system dashboard than we've currently got, and also a comprehensive plan. So that they're the things that we are working on at system level at the moment, ahead of the next visit by the national team. In terms of, so yeah, you're absolutely right, Simon, COVID numbers are decreasing hugely. So we've got 10 patients in our hospital today. None of those are in ITU, so that's really good news. And I am hoping that after today, we will be able to relax our visiting restrictions somewhat. We are currently working on that across the group. In terms of fall safety, so yeah, the CQC visited in March. That's on the agenda later. I won't steal Fiona's thunder on that, but again, just wanted to say a huge thank you to everybody that was involved in the huge amount of work that's taken place over the last 12 months to make sure that our patients are safe on our wards. We've celebrated many things over the last couple of months, and I've highlighted some of those in my report. Admin Day, Nurses Day, Midwives Day. These things are really important for us to celebrate in the organisation. It gives a real sense of team, and it also gives that just additional time to stop, think, reflect, focus on the future, have some cake and coffee, and feel a little bit more motivated as you go into your day's work. There is one thing that I would just like to draw out of what we are achieving at the moment, and that's that we are one of 9 endoscopy units in the country who are taking part in a UK trial. And that's using artificial intelligence. The device is called GI Genius, with the aim that we will start to improve the detection of cancer. So I'm really pleased that we're part of that. It's a really important piece of work. I'm really looking forward to seeing the outcomes. Moving on to EDI, there's just 2 areas that I'd like to mention. The first one is around the rainbow badge. So our LGBTQ network arranged with a charity called Stonewall a staff survey to take place, and that's taken place over several months. Stonewall is a charity that supports LGBTQ members by positively focusing on the lived experience, what it's like, and really starting to get a social movement going around how we can positively change the lives for people. So we're waiting the outcome of the survey, and when we do receive the outcome, we should hopefully be awarded with either bronze, silver or gold award, which is great. Looking forward to that. And then the other thing just to celebrate is that our EDI lead, Carol Werner, has been shortlisted for a National Health and Care Award in the category of Inspiring Diversity and Inclusion Lead. So I'm sure we'll all wish Carol lots of luck with that. I'll finish with patient and staff experience, and as colleagues know, our staff survey results were disappointing this year. I was personally disappointed, as were the rest of the exec team. You'll hear later on in the agenda from Paula a little bit around what we are doing in that regard. But with the need to improve both staff experience and patient experience in the hospital, I hosted a hospital management team away day in April, and we focused on staff experience, which was led by Paula, and patient experience, which was led by Fiona. And that's really about pieces of work that we're going to be taking forward over the next year to really start to improve our patient experience and staff experience, and make sure that our staff are advocating for our wonderful hospital. So I will stop there and happy to take questions, Chair.
Okay, thank you very much. You can have any questions on either of those two reports. I thought International Nurses Day was pretty good in the hospital, and those of you that haven't seen, our new senior nurses are now wearing black, not red. So don't be surprised when you look at one of them and think, why are you dressed like a security guard? But sorry, only a joke, Fiona. No, they're very smart and they're very good, and they're aligned with Northampton, of course. And there is actually a whole national thing for nurses' uniforms going on, which you can only imagine how difficult that must be. But anyway, congratulations on the whole International Nurses Day. Alice.
Thank you, Alan. Just a question to Debbie, I think. You mentioned that now we're out of the discharge programme pilot, we are struggling to sustain some of those improvements. Is that around the integrated plan that we need in place, or is there something else to that, Debbie?
No, there's a couple of things, Alice, and of course it's never simple. So we're still part of the national discharge team. We're one of 14 trusts. There are 4 work streams within that, if you recall. One of them is about focusing on pathway 0 patients. They're the patients that don't need any care when they leave hospital. So in that regard, what we are doing, we're making sure that every single patient is seen every day. We've got board rounds in place. We've got senior challenge in place every day, making sure that we're planning for tomorrow's discharges today. There's a whole ream of work, which I'm sure Faye will want to talk through. The other 3 work streams are predominantly focused around the community, and the capacity in the community, as we know, has been fairly limited. So the community colleagues are still experiencing the same difficulties that we do with regards to unavailability of staff, sickness, and I know that both councils are experiencing quite high levels of unavailability at the moment. So of course those patients do tend to stay with us for longer periods than we would want. Whilst they're staying with us though, I must note they are still being very well cared for and still having rehab on our wards. So it's not a mixture of one thing or another, if I'm being really frank. I think we've had some sickness, we've had some difficult issues with some of our medical colleagues over the last couple of weeks. We've had to close our SDEC, our same day emergency care area, early in the evening. That will have had an impact. So I expect that this is a blip over the last couple of weeks, and we have got plans in place to increase the opening hours of SDEC going forward. We're increasing our weekend discharges, weekend discharge ward rounds rather. So I am hopeful that we will start to recover and decrease our stranded and super stranded. And of course, as an exec team, our priority over, well, our ambition over the next 12 months is to, by next March, have no super stranded patients in the organisation. And that's the right thing to do for our patients.
Thank you, Debbie.
Okay, thank you for that. I've made a note of that ambition, Debbie. I'll come back and talk to you about it in March.
Okay, thank you.
And I think the only other thing I want to say is I'm sure the board, and particularly the non-execs, would want to strongly encourage you to get back to proper visiting. As the national leadership of the NHS says, this is an important part of patients' welfare, particularly those that are in hospital for any length of time. So I'm sure we'd encourage you strongly to get back to proper visiting for our patients. Okay, thank you very much. Integrated governance report. I think we're going to start with Andy, and then I'd like you to just move seamlessly on to Debbie to compare the Debbie committee show and take us right through the IGR. Andy, thank you.
Thanks, Alan. So you'll see in the pack there's an update on the progress of the IGR. This month we've increased the number of metrics compared to last month by 2, but you'll also note there's some more narrative adding in. Clearly there's still more to do. In the pack you've got an understanding of what metrics are still working through their definitions. So 57 of the 89 have been defined and they're marked in red in the pack. And we're working with the exec and operational teams on a one-to-one basis to work that through. And we'll also be asking the executive leads to work with committee chairs to prioritise which metrics next are the most important to have. you'll see we're estimating it will take a further 3 months to get the metrics fully defined and data flows in place, and then another month to refine the visualization. So we should look forward to the September board to having the full set of agreed metrics in the IGR, obviously recognizing that as we approach that, we'll get more and more as we get there. Just wanted to give a bit of background on why this has been a challenging process. And you'll see in the pack, there's a bit of a timeline of how when the data becomes available and then the narrative being added and then sign off, etc. And you'll see there's only 2 days actually for a final review and sign off, which you can imagine is pretty tricky when we've had the kind of operational pressures that we've had of late. We have looked at some other NHS boards and seen that the majority you actually use data that's 1 month in arrears. And I think this trade-off between the currency of data and the depth of analysis is probably something we'll come back to in the next few months. I also want to highlight the next iteration of the look and feel. You'll see in the final part of that pack, there's an appendix, and this has been based on feedback so far. And I'm really pleased about that, and you'll see that in next month. And I hope you'll agree too. It represents another step forward. And just as I come to a close, I just want to thank colleagues for their patience as we work through the IGR development. But the question is, what view should you form from this? Is it all doom and gloom? Absolutely not. And I don't want our board to take the challenges of developing the group IGR as an indication that our organisation is running blind in terms of data. It's very far from it. And just to help your understanding on that, this week I've shared a short report with you all that shows that our teams across the group complete nearly 5,000 statutory returns each year, provide over 150 real-time or regular reports to support operational decision making, and also are working their way through over 1,100 ad hoc report requests. So yes, the team is challenged to meet demand, and yes, we certainly do need to invest in transformation in the way we deliver health intelligence. But I would like to assure the board that this is very much the top item on my priorities, and I can assure you I'm working really hard to address this. So with that, I'll hand over to Debbie. Thank you.
Just on that point, before you go to Debbie, I think 2 things, Andy. One, I'm absolutely certain we're not going to agree to do business with data that's a month older than it currently is. So we just need to think our way through the pattern of committees and meetings. And I would also encourage you to look very hard, because I cannot imagine that those 1,100 ad hoc requests are actually looked at by quite a lot of people making them. So I'd strongly encourage you to do a real cull of those things. You might even just consider stopping those reports and seeing if anybody complains. So I would strongly suggest you do that. But I want to be really clear: we're not going back to month-older data. Whatever else we have to do to order to make this system work better for staff, for the directors, and for your staff, and for the board. Debbie, over to you.
Yeah, thank you, Chair, and thanks, Andy, for that update. I know that you've also had some significant staffing challenges, and you and the team are doing a fantastic job trying to get to the bottom of some of this, so thank you. So we'll start with the Quality and Safety Committee, and the committee met earlier this week. Unfortunately, the committee chair is on annual leave at the moment, so I will give a very brief overview before I hand over to Fiona, Rabia and Faye. There's just one area that I'd really like to highlight on the summary paper, and that's around health and safety. So the committee received a health and safety update from Liz Housden, our Director of Estates and Facilities, and this was in relation to the incident which took place earlier this year. She provided a 16-point action plan that was presented to the committee, along with an overview of progress and the improvements that have been made within the Estates and Facilities Directorate. The committee was assured that progress was being made and that progress was good. That was, from the summary paper, the only update that I wanted to provide, but I wonder whether or not Fiona first would like to comment.
Thank you, Debbie. So within the Quality and Safety Committee, we also looked at our inpatient falls and our maternity update in relation to Octon, both of which are on the agenda a little bit later. However, I would like to give an update in regards to our complaints compliance. The board will remember that last month I presented a paper to look at where we were, where we had been, and what our progress and plan was going to be to improve our complaints compliance. And I'm pleased to say that we have continued to have a month-on-month improvement in our compliance with our complaint letters, to the point that in April we are now sitting at 67%. I recognise that is well below our target, which is 90%, but it is above our internal trajectory that we have set ourselves. And although we haven't reached the end of May yet, indicative figures suggest that we'll probably be at about 75% for May, but I will be able to clarify that and continue to monitor and report our progress through quality and safety. Thank you, Debbie.
Great, thank you, Fiona, and that's really good performance above our internal aspiration. So thank you. Rabia, can I bring you in, especially on mortality, please?
Thank you, Debbie. Yes, so also in the Quality and Safety Committee, we talked about mortality. I presented that our mortality rate as per recorded by SHIMI is above expected. And just to elaborate what SHIMI is, actually it's summary hospital level mortality indicator. And that is one of the way mortality is measured. There are 3 ways, standard ways in which mortality is measured across different trusts. And SHIMI is one of them. HSMR is another one of them. And what I wanted to say at the beginning is that by HSMR and SMR, we are as expected when it comes to the mortality. But in particular around SHIMI, the way SHIMI calculates the deaths, we are highlighting as above expected. This is for the last reported data period, which was up to December 21. These are retrospective figures, but at the same time, the other difference between SHIMI and HSMR is SHIMI also includes deaths 30 days after patient has been discharged. So there is a little bit of a difference in how things are measured. Irrespective of all of that, it is disappointing and concerning. So we are doing a deep dive with the help of my medical and nursing colleagues and data quality team and NHS digital team. I am looking at the data which has been submitted and different reasoning. One of the conditions which have highlighted as an area that we need to look at with excessive death is pneumonia, including COVID. And so we are doing a quite significant piece of work around that. And the other area which stands out, but is not highlighting as an outlier, but we certainly are different from our peers in the region, is palliative care provision in the community. So we are looking at that as well. So what I just wanted to say is that we are doing a significant amount of work looking not only on data quality, but also on clinical service provision, teaching and training moving forward, and also re-established our deteriorating patient group and learning from death groups to see how we can extract any further learning points from this particular finding, and also working very closely with Northampton General Hospital to learn from them and see that how we can work together to bring it to as expected level and or below expected level, Debbie.
Lovely, thank you, Rabia. Faye, we've talked a lot about discharge. Is there anything you would like to add?
Yes, thanks, Debbie. So just briefly, really, to assure the board about some of the plans that we put in place for the bank holiday weekend. Obviously, with us being under so much pressure over the last week. So today we are running our Home for the Jubilee event, which is a multi-agency initiative. We've got our system partners on board from Adult Social Care, NHFT, voluntary sector, and the plan is to try and get as many people home as quickly as possible for the Jubilee if they are medically fit to do so, and that's targeting every patient on every pathway. So we're really hoping that that will be a success today. Just to pick up on Debbie's point around our same-day emergency care area, yes, we have had some challenges, but we have got a plan in place for the weekend, so that's really good news. And we've also looking to staff our escalation ward should we need it. So we are belt and braces for the bank holiday, and we hope that those plans will not be required, some of them, but they're there in place if we need them. So thanks, Debbie.
Thanks, Faye. If we take questions at the end, Chair, if that's okay. Performance and finance, please, Damien.
Thanks, Debbie. Good morning, everyone. Yeah, so we met on the 20th of May, and I think a lot of what we discussed in the committee meeting has been mentioned in passing at one point or another via either your update or Simon's. Just on the performance metrics, I think as you both acknowledged, in some areas we're not kind of tracking to targets. For example, RTT we discussed, I think at the end of April, there were 42 patients with an RTT of 52 weeks or more referral to treatment time. But that does include 10 transfers from University Hospital Leicester, which came across with a wait of over 104 weeks. I think the assurance that we took is that that number 42 had already been reduced to 33 by the beginning of May, and that there was a weekly focus on bringing that number down on the patient treatment list. Cancer, I think, good news is 3 of the standards were met: the 28-day fasted diagnosis, subsequent drug, and 31-day first treatment targets were met, which is great news. Some targets were not met, and we heard from Faye that part of the reason behind that is a national capacity issue with robotic surgery, as well as some patients still delaying treatments, etc. So there's a whole raft of reasons why those are not being met. I think overall the assurance we took when we look at RTT and cancer is that compared to other trusts and the national scene, Kettering is actually doing really, really well, which I think is testimony to all of the operational and clinical staff. On diagnostics, MRI and echo are still behind their recovery trajectories as of April. I'm sure that Faye will say more about this when she gets to talk, but I think there's a deeper dive required there, and Faye and the team are very focused on that. You've already mentioned, Debbie, super stranded, which was at 109 when we met, and stranded at 264, and you've explained that some of the reasons for that is capacity, wider capacity in terms of being able to discharge those patients into other care packages out in the community. I may as well cover the money as well. So from a finance point of view, there was a very small adverse variance of 140k in month one. I think there were some fairly conservative assumptions made around the levels of income. So, I don't think there was anything to worry about in terms of that negative variance in month one. We approved 6 business cases. I'll not go through all of those. They're in the papers for the committee, 5 of which were targeted at clinical improvements, and 1 was a group-wide digital initiative to implement single sign-on, which I think theoretically should make it easier for people to access systems at either trust, KGH or Northampton. We also received a paper on the capital plan for KGH, which is 12.8 million in total, as well as an overview, and I think this is the really interesting thing, of more robust governance arrangements around that capital plan to ensure that we don't end up in a situation like we did in last fiscal, where there was still quite a lot of capital spend that needed to happen, not just in Q4, but actually in the last month of Q4. So we took some good assurance around that. I'm sure John may talk about this, but he also briefed us on the tension that remains from a system financial plan for this fiscal year between levels of operational performance versus system deficit. And as we understood it, that hasn't entirely settled down, and those discussions are continuing with NHS as to the overall financial plan for the system. They would be the main things I would bring the committee's attention to. Thank you, Debbie.
Thank you, Damien. John, is there anything else that you'd like to add?
Two things, if that's okay, Debbie. So just to kind of flag that, yes, we were broadly in line with plan as Damien's articulated. Again, I'll flag nothing to worry about and reiterate the conservative assumptions. I will say, however, that's in the context of it's the month one plan for a plan that we're going to need to resubmit with some improvement on. But I'll get onto that later on in the agenda if I may, and when we come to it. But that's worth flagging. And the other thing to pick up is we haven't had a board where I've reported on year end. And so just for the minutes, we will have at Kettering, subject to audit, have posted a year end deficit of £360,000. That's materially in line with the break even target that we were set. So I'm pretty comfortable with that. And the reason that there was that small deficit compared to break even is because we were successful, I believe, in committing some more spend to areas that we'd agreed to commit to for one-off areas, in particular kind of estates type spend and digital type spend to help hospital environments and digital infrastructure. So I'm entirely comfortable with that, and that was in line with the briefing that I provided with Finance and Performance Committee before year end. I will say, because it was referred to around capital, that probably two bits of good news and one not so good bit of news on the capital at year end. So one was we were successful in committing all of the money that had been allocated to us for targeted investment funding. Some £3 million that we received in the second half of the year. We committed that money in full and spent it on programmes, I believe, in a value for money and effective way. We delivered on all other areas of the programme bar one. And the area that we didn't deliver on was a specific programme around energy enabling works. Where we had set up, agreed, procured, put in place arrangements to spend that money in the last month of the year. Due to contractor unavailability, sickness, and scheduling, etc., we were not able to progress that on site, and therefore didn't commit and spend that money by year end. We've done a review of that. I think there's further work to do as Damien has referred to in terms of how we pull some of this spend further forward and earlier in the year, so there isn't so much of a peak at year end. But other than that specific point and that programme, which will be progressed in the new financial year, everything else delivered in line with plan.
Thank you, John. Faye, is there anything you'd like to add on performance?
Yes, thank you, Debbie. Just a couple of things to note. So thanks, Damien, for the comprehensive update on performance. Just to add, though, from a mutual aid point of view, we are still being asked nationally to support some of our hospitals, not even local hospitals, some as far as Wales, actually. So it's just really to say that, nationally, there are still some very long waits across the country. And given our position, we are being asked to help. And where we can, we are. So just to note that. As Damien mentioned, diagnostics has been an ongoing challenge for us, probably for the last 8 to 9 months. We're now at a point where we really do need to have that deep dive to understand what is the position. We're conscious that we've set ourselves a trajectory and plan and that we've not achieved that. And we absolutely need to get that back on track. So at the next board, we will bring a plan of how we're going to, what the issues are and what it is we're going to do to turn that around and get that back on track. From a cancer perspective, as Damien says, we're doing pretty well in terms of the 28 faster diagnosis. But I'd just like to bring to the attention of the board that we do actually have some long waits in terms of the 62-day pathway, particularly for patients that are waiting robotic surgery. And some of those patients are over 104 days, which is quite significant. We are working with Leicester, and we are working with other providers to see what capacity we can source for those gentlemen that are waiting robotic surgery, but there is a national shortage. The good news is that NGH, as we know, have recently got their robot, and we hope to have more capacity online July, August time, which means that hopefully we will start to send our patients over to NGH, and we will shorten that journey for those patients. Just to assure the board, we are in regular contact with all of our patients that are over 104 days. They are being offered additional follow-up appointments, additional scans, etc. And we will be monitoring to make sure there is no harm caused to those patients. So that they're just the things I wanted to raise. Thank you, Debbie.
Thank you. My mouse is playing up today. I couldn't come off mute then. Thank you, Faye, for that. And I think we are currently the best performer for 28-day faster diagnosis in the region, aren't we? So fantastic performance in that regard, but clearly need to do more, and we are doing more with regards to what happens after diagnosis. So if we can move on to people, and Lisa, please, I think you're covering.
There's a couple of hands up, I think, Polly and Simon.
Yeah, I was hoping that we'd be able to take some questions at the end.
Oh, yes.
Okay, yeah. Thank you. So can we move on to Lisa? Yep. I think you were covering people, Lisa.
I am. Thank you. Good morning. Yes, I covered the People Committee, the Joint People Committee on the 23rd of May and was the Deputy Chair on behalf of KGH. It was a very full agenda on the day with many of the topics actually on the agenda here for the board later today, including the staff survey and the planning for 22 and 23. In terms of things that I'd like to highlight, we started by reviewing and reflecting on the pulse and the staff survey. As Debbie alluded to, I think the overall feeling was that we were somewhat disappointed with the results of the survey, but really we took an approach of really questioning what we could further do to help improve that situation, making sure that we are investing our resources in the right way to try and help and support the staff. We tried to gain assurances that appropriate external benchmarking had been done, but importantly also to ensure that those things that we were investing our time and money on were having the right impact on the staff, and there wasn't more we could do. 2 points that came up particularly was the first, the cost of living, which Simon referred to in his opening speech about, is there more we could do to help our staff? And we used data and analytics to understand quite how widespread the impact of that cost of living was on the staff. And the second deep dive area was particularly the support for mental health of our staff, and really looking at the differences in terms of the support that we provide across the two trusts, really questioning ourselves about whether or not both trusts received equal and appropriate care. We then moved on to safe staffing and vacancy rates across the hospital, and really here looked particularly, recognised the challenge in terms of recruitment, but really looking again here particularly at how we drive consistency across the two trusts and consistency in terms of pay and conditions, with a particular deep dive in terms of the way we approach bank and agency staff. Finally, then we looked at the plan for 22 and 23, and I think if Mark were here, he'd want us to highlight the fact that there is still a gap in terms of our operational plans and some of the risks associated with that plan, and I'm sure we'll touch on some of those later as part of the agenda item. But in terms of the committee, we took a bit of a deep dive then into how do we ensure we are not just recognising the gaps, but really looking at the efficiency, reflecting on the fact that the number of employees has grown substantially over recent years. As we now return to more normal conditions post-COVID, how do we ensure that we've got staff efficiently deployed in the right areas, and use that as a way of leveraging those opportunities to close that gap that we currently see on the page. And I think that is for the key things I wanted to highlight, Debbie.
Thank you, Lisa. Paula, is there anything that you would like to add?
Yes, I was just, excuse me, just going to pick up on, Simon challenged us earlier in his piece around, are we doing everything that we can do to support our staff? And we did have quite a lengthy conversation, Lisa's right, in the committee earlier in the week. And I just wanted to provide a little bit more assurance, I think, around that. So we're really trying to approach this from a number of different directions. So in terms of very practical things that we can do to support people. So our volunteers are currently developing a new scheme called Wellbeing to You, where we're actually going to be taking out donations of food and other helpful products to staff who have expressed that they would be in need. Be appreciative of that. So similar to some other trusts that are using food banks, we're taking a slightly different approach. And again, brilliant support from Emma and her team with the volunteers around that programme, trying to make sure that we are discreet, but helping those in need. We have agreed as an organisation, along with our partners at NGH, to introduce wage stream, which will mean that our staff can access their pay in different ways, which will give them more flexibility and control over access to their earnings, which we hope will be helpful for those that need it. We have also got support for people in terms of education. So it's not just about providing sort of direct support, but also helping people with the education around this as well, in terms of budgeting, financial planning, looking after their money. So trying to do that as well. Plus, of course, making sure our psychological support services are there for those who really are in a tricky situation and need support. And picking up on Lisa's point about how do we know what's going on, clearly we've got lots of sources of information. So on Let's Talk, on a Wednesday, we hear from staff about what's impacting them, people coming into the open office and the We Care Cafe. We're changing the staffing arrangements in the We Care Cafe, so it's going to be a served service with much more sort of proactive and more support from our volunteers in there. So our opportunity to hear from our staff, and again through the pulse, as Simon mentioned earlier, is significant, and we collate all of that information to make sure that we're really trying to design a range of services that will support staff in whatever way is appropriate. So just wanted to add that. Thanks, Debbie.
Thank you, Paula. So if we can move on then to digital, please, and Alice.
Thank you, Debbie. Yes, it was an incredibly packed digital hospital agenda, so much so that we've decided we need an interim one in June when we wouldn't normally meet, because there's quite a lot that is going on in digital, as has been referred to in a number of other items. The key things that we talked about this time that I'd want to highlight to the committee, although it's NGH, I do want to just mention the EPR plan for Northampton, because it has a big impact on what we do collaboratively with Northampton. We are struggling with the national timelines, if you like, to grant us funding for implementing our EPR at Northampton, and that is taking us disappointingly far out into the future compared to what we might have hoped. Therefore, we've challenged Andy and the team, and he's accepted that challenge, I think, to come back with a review of what we're putting in place in terms of interim measures, which are there, but I think it's probably a case of making those more proactively available to clinical teams who are collaborating to fill any gap that we might be left with, and also to challenge that timeline to see whether we can get that any closer than our initial estimate. We also talked quite a lot about the implementation of the elective care projects that we've got from our recent TIF funding that we received at the very end of the last year, and about how we smooth the implementation of those. We obviously talked about the IGR, which we have touched on, so I won't go into in more detail. And also somebody referred to, I think, the ICS digital strategy, which we spent quite a long time going through, and we were tremendously welcoming of. Shouldn't be coincidence, because we were heavily involved in influence and direction of that, but we were pleased that it really chimed with what we would want to achieve as a trust digitally and was really aligned. So saw that as a really positive step forward, that we've got acceptance at an ICS level of that direction of travel that we're on together. We also approved the case for the robotic process automation project that's actually going on at Northampton, but benefits both trusts, and also really helps us to help other trusts. Again, going back to that mutual aid in a different way, where we help other trusts across the country and helps us attract the best and brightest people to our digital team as well. Andy updated us on the digital team restructuring as well, and how that is going and what the plan is for that for the rest of the year, to bring that fully together as a group team. And we also talked about the Northamptonshire Shared Care Record project, which unfortunately is still somewhat in delay. Andy may be able to give me a more up-to-date date in a second, but we are not quite there yet but a team is working very hard behind the scenes to get us over the line as soon as we can this summer. Happy to let Andy add anything to that.
Thank you. Andy?
Yeah, just two things. So on the robotic process automation, what we just need to stress is that we approved to continue on as we are. I think what we talked about is some different ambitions, and there's probably more to do to develop that as options that we'll discuss as a committee. On the Northamptonshire Care Record, at the board this week, we had a good understanding of what the barriers are to going live, and the committee set itself the challenge that when we meet in June, it will be about celebrating the go live. Now, we have been here before, but there was a number of clinical safety issues that I think have been resolved over the last couple of weeks that makes me feel more confident about that. So we took a collective acceptance of the challenge about that. And so we hope to be delighting you with the news as we go into next month.
Thanks, Andy. And Alice, we're staying with you for Collaboration Programme Committee.
Yeah, absolutely. This one's a bit shorter, you'll be pleased to know. So the last meeting that we had 3 key agenda items, which I'd want to just flag to the board, particularly as the papers are there if anyone wants to go through the detail. Firstly, we looked at the ICS plan and strategy thinking in terms of what are the priorities for us to get involved in as a trust, and what would we want to be involved in to varying different extents, and formed a first view on the areas that we really wanted to focus on a trust, which will no doubt come to the board in due course. We also looked at the governance proposals for the elective collaborative as well, and understood the transition between how we govern elective work now and how we would look to do that in the future. And we're satisfied that that represented a sufficiently ambitious change that we hoped would deliver some of the real changes in behaviour and ways of working that we're looking for the people of Northamptonshire on that. And then finally, we spent some time going through the initial findings of the review of group estates and facilities that we've had conducted by an external third party, which identified some potential areas for us to look at for improvements in what we offer and efficiencies in what we offer as a group of hospitals. And we have instructed the team to go back and further flesh out those areas for us to explore, acknowledging that whilst patient care is really paramount, there are ways in which we can potentially do that more efficiently in a constrained financial environment.
Thank you, Alice. Simon, is there anything that you'd like to add to Collaboration Programme Committee?
Nothing, thank you.
Thank you. I'm still with you, Alice, on audit. I believe you were deputising for the chair.
I'm Deputy Trevor today, yeah. So a couple of the things we talked about are further down the pack, so I won't go through those in detail. But we had quite a busy audit committee. We approved the external audit, annual strategy and plan, and also the internal audit, and including counter fraud, strategy and plan. So we're happy with the plan in place for those. We also noted, I think particularly on internal audit, that compared to where we were 18 months, 2 years ago, we felt we were in a much better position as a trust. And that we had been concerned 18 months, 2 years ago about the amount of internal audit work we were achieving versus the plan and the risk areas, but we were now in a very good position of achieving the plan and back on track and back in a really good position. So we were pleased to hear that. The self-certification is further down the agenda, so I won't say anything about that now, as is the audit committee terms of reference, but we approved both of those for coming back to the board today. We also talked for some time, and John may want to say something, so he may not, around the accrual for annual leave and the accounting method for that and so on, and asked for an update on the timetable to deal with that. And I think that is all.
Thank you. John, is there anything you'd like to add?
Thanks, Debbie. So two things. So we did, as Alice has said, gave an update and a run through for the committee about the big accounting estimates and judgments that we'd be working through with external audit as part of year end. Those two were, so the first one was annual leave accrual, and we took to the committee a summary of the paper that we'd already discussed and agreed at our group executive management team around the process for constructing that accrual. I won't go through the detail now, but just to say we went through that in some detail, and it was supported at the committee, and we'll take that through in terms of the accounting estimates with our auditors before we close off the accounts. The other piece of work that we took through to the committee related to the evaluation of our estate. So colleagues may be aware that we had some particular problems last year and the year before around the accurateness of the valuation of the estate and the implications for that on the accounts. I'm pleased to say that our external auditors said in public that they were comfortable with the work that we had done between finance and estates, the data that had been provided and the assumptions that would then be used to underpin year-end audit for this year. And as importantly, that there will be no prior year adjustment where prior year accounts would need to be restated because of those changes. So that was a very positive view. I'd like to put on record the significant amount of work that's gone into improving the internal audit position, both with colleagues within finance, internal audit and across the organisation. I think it's a combination of two things, one being more realistic and measured in terms of the deliverables in response to items and concerns that have been raised, but also a pretty relentless focus on closing down actions. And as Alistair said, that was widely commended at the committee. Thank you.
Thank you, John. So I think we can move to questions now, Chair, as we didn't have a strategic development committee that was replaced by HIP2 OBC qualitative appraisal this month.
Thank you very much. That will be Hospital Improvement Programme outline business case. Simon and then Polly.
Just wanted to comment briefly on the mutual aid position. So the QSRM gave a clear steer on this. Firstly, nationally, mutual aid is not going to go away anytime soon. In fact, the message was it is here to stay. As I said previously, we are in a fortunate position with regards to our waiting lists. Many other parts of the country are not. The system that we've been encouraged to adopt is a direct transactional conversation with other hospitals who approach us, hence why Faye was talking about hospitals as far away as Wales approaching us. I didn't know about Wales, but there's always it's always good to find out how far away your ambit of influence reaches. So the instruction is to us that we are one NHS, and if it were any of our relatives, any of our friends living near those hospitals, we would want to help. So we need to start from that premise. That said, and John and I have been talking about this, we clearly have to make it not disadvantageous for us. Regional colleagues have been clear, and I just wanted to qualify the point that was made around breaches. We will not in any way be penalised for taking on a patient who is a significant long waiter from another area or region, nor will we be penalised in terms of money. We're about to have some more of those discussions at UHL. So I just wanted to make that clear for the board today. Thanks.
Polly.
Thanks, Chair. So two just very quick points for me. The first being Faye's discussion about the diagnostic weights. So just to confirm to the board that we are taking part along with system partners in putting together a business case for community diagnostic centres. So that will support a reduction of our diagnostic weights by allowing those patients who are outpatient diagnostics to be seen and treated or seen in those community diagnostic centres. Outline business case due to be submitted at the end of June, and hopefully with the first one beginning to open in early 2023. The other point that I'll just make on the collaboration programme committee about the elective collaborative is just wanted to add to Alice's point that the governance that we have approved and the steps forward have been fully supported by our senior clinicians across the group. And in particular, we met with the Kettering clinicians this morning. They're wholly behind it as a really exciting opportunity to transform elective care for patients in our county. So just wanted to add that. Thank you.
Okay, thank you very much. Anything else, anybody? Nope. Okay, thank you. John, the Integrated Care Board National Plan submission, as you alluded to earlier, this has gone through a number of iterations and it's not yet finished, and the financial ask is getting more rigorous. Perhaps you'd just like to take us through where we are. I'd just like to mention to non-execs in particular, I'm sure executives will obviously be spending a lot of time on this planning before the date of the next submission, but from a non-exec point of view, this will be by far the biggest item, maybe even the only item, but certainly the biggest item on your non-exec director away day, to give you a very thorough understanding of the trade-offs that are being considered, any developments that are being made, and how we're going to handle the increasingly rigorous, and rightly so, financial demands. I'm sure taxpayers would expect the NHS to live within its resources, and the parliamentary vote is, in the end of the day, sacrosanct. So in that sense, we do have a lot more work to do on the planning round. John.
Thank you, Chair. So I'll take the slides as read. I'll pick up the kind of where we landed in our submission at the end of April, and then kind of what that means in terms of moving forward, as you've already alluded to. So in terms of the submission at the end of April, again, it was a system submission of which we are a part of. We submitted a system plan that said we were compliant against the ask on elective activity. That is that we deliver 104% of our 1920 pre-pandemic levels of activity. We were compliant in terms of that submission. We're also, I believe, one of the only systems that submitted a position where we were expecting to have 0 52-week wait breaches, notwithstanding the conversations around mutual aid and transfers from other systems. So that was significantly better than the national ask, as colleagues will know. So on the operational side, we presented a very strong and positive position. On the money, it was not quite in that same place. So we submitted a plan across the system that showed a deficit of circa £50 million. That's 50 million pounds. And I'll put in context, no single system nationally presented a break-even plan, which was the ask, predominantly due to the challenges that we're seeing around excess inflation, and also the ask on us around improvements in productivity, effectiveness, and essentially moving back to a cost base that was in place pre-pandemic. As you've already alluded to, that puts us in a very difficult position. It puts us in a difficult position around our system conversations. This is a system plan. We have put in capacity, certainly on the urgent care side, to deal with challenges around increased attendances in A&E. And colleagues have already alluded to the challenges that we continue to have around significant patients that have been staying within our hospital despite being medically fit for discharge, those being termed as stranded or super stranded patients. So we are working through how we as a system balance those conversations out. Those conversations have been had with regional colleagues, and I think it's fair to say that even nationally, that trade-off is not yet in a settled position. What is clear, though, is that there's a focus, absolutely focus, on putting back in the levels of controls that were in pre-pandemic. We, for quite right reasons, kind of moved into governance light and control light, given the operational priorities and challenges that we've had, not least in the pandemic, but the winter that we've just gone through, which has seen significant challenges. The expectation nationally is that those controls start to come into force. We are talking about controls again around temporary staffing and other things, and we'll be asked as a hospital, as well as a group and a system, to be able to explain and justify the proposals that we're putting forward and all the steps that we're making to make best use of the resources we have available to us. You've already alluded to, but I'll just kind of give a bit of clarity in terms of how we move forward. So we are being asked to submit as a system another plan or another iteration of the plan by the 20th of June. That is a full resubmission across activity, performance, workforce and the money. The ask of us certainly on the money is that we are expecting to receive additional funding to cover the cost of excess inflation. Those numbers are to be determined, but somewhere between kind of 15 and 17 million. And the balance of that, so somewhere between 35 and 33 million, we're being asked to find ourselves to deliver break even. That is clearly a very challenging ask to do, not least in the time frame, but also given all of the other challenges that have been described. We're working collaboratively with our system partners, and we have a plan to work through those specific areas of the organisation where we have seen a marked change, for example, availability due to sickness or other reasons, albeit because of capacity that we've put in specifically to support the pandemic, which under our national planning asks we are to assume is very low to none. And we've also been asked to assume that we have a relatively light winter, both of which may not come to pass, but from a planning assumption point of view, those are kind of the tram lines we've been asked to work through.
Thank you, John. That's fairly comprehensive. As I said, we will be talking a lot about that when non-execs about what that trade-off means, and some very difficult questions and trade-offs, but it's an entirely reasonable ask as you return to governance proper. Any questions or comments at all on John's? Nope. Okay, thank you very much. Group clinical strategy. Rabia and Polly, I think, are taking this one through. Just remind people that when we approved our group clinical strategy around about Christmas, we were very clear this was our version of what we wanted, ours being the wider group amongst our staff, our clinical leaders and so on, but our version of what we wanted. And in the intervening few months, we've been taking it to all sorts of other groups, discussing it widely with patient groups, governors, staff, partners in the system, and so on and so forth. The only area we haven't managed to do that properly in is the health and wellbeing boards, because their meetings were cancelled, but we will catch up with them before too long. So this is now the amended version, which has gone through all that consultation and has taken on board as many of the comments as seemed appropriate. So congratulations to the people who did all that work. Now you can tell us about it and where we've got to. Polly, Rabia.
Thank you, Chair. Polly would be kindly sharing the slides, and I think Matt Metcalf, Medical Director from Northampton General, will be joining us if he hasn't already joined us already. So I'm really pleased to have them with me as well, and really pleased to present the refined version of clinical ambition, which has taken a shape of clinical strategy today. Just a very high-level overview, and then be happy to take questions in the end. And we presented our clinical ambition just before Christmas in the November board for collaborative working as a group. And building on that work with extensive consultation and engagement with different stakeholders, which Polly will be talking about just in a couple of minutes, we've been able to update and refine our ambition into the strategy. Polly, if we can move on to the next slide, please. I think so that's fine. Our clinical strategy is based on quite a compelling case for change, based on our real-time and future challenges that we face, including critical staff shortages, impacting on staff recruitment and retention. And also demographically, our population is growing and aging much faster than the national average. We are really proud of some of the really exceptional care we offer. For example, our acute coronary syndrome, ACS outcomes are one of the best in the country. Similarly, mortality due to acute myocardial infarction is the lowest in the region. But at the same time, we are very aware that there are unwarranted variations in different services across the county, and there are areas that we can improve on, and certainly our patients want more joined up care, and this fits in with the direction of travel set by nationally as well for integration and collaboration. If we move on to the next slide, Polly, and I mean, our patients' voice and their feedback has been pivotal in shaping our clinical collaboration. And we heard in the morning from Amy regarding Katie's story, a spectacular story, as she stated. And we want that experience to be shared by each and every one of our patients, if possible. And that is what we are aspiring to. Our board heard about some of our patients in the past few months. And we know that the patient experience is not quite where we would like it to be for some of the aspects of the care we provide. For example, if we can recall Bernadette's story and her disappointing experience of disjointed care between the two trusts when she had to move from one to the other, certainly it demands improvement in care with regards to that. We know cancer and heart disease are the biggest killer in the county. And Nikki's experience of her breast cancer treatment when she had breast surgery, which she shared with us, she highlighted quite a lot of great care she received. But also, I mean, I can tell from personal experience how devastating it is for a patient and the family when you get given a cancer diagnosis. And on top of it, if care is not as it should be, it just makes it a whole lot more difficult. And Keith's story we heard in one of the recent board meetings and also in our cardiology conference, who is a fit firefighter. And he shared his experience of when he had a heart attack recently and how he had to go through different channels before finally ending up in cath lab and getting the treatment he really needed. And the subsequent treatment was great. So, I mean, what we really want is we want to get it right the first time for all our patients. We need to do it for Nikki, for Keith, for Bernadette, and for everyone in the community. Polly, can we have the next slide, please? And I think at this point, I'm handing over to you, Polly, to take us through all the engagement work that has taken place and the few updates that had been made in the clinical ambition document.
Thank you very much, Rabia. Yes, delighted to take people through an explanation of the wide engagement that we've been doing, both in the development of the initial ambition document and then since then over the last few months to refine it further into what is now being presented as our group clinical strategy. So this slide just sets out the engagement we did do initially to work up the November ambition document. So it was a very wide set of engagement. We did a big staff survey that was one of the most popular staff surveys we've ever done, actually, and nearly 500 responses on that. And over 80%, but what was really good to see is that over 80% of our staff felt that collaboration across the group and clinical collaboration across the group was the real way to improve care for patients and improve the staff experience as well, improve their training and development opportunities and recruitment ability to recruit into services. So that was really positive, and that set us on a very good path to developing our ambition document. And we then had over 200 people come to some clinical conferences. We had many more people get engaged in clinical pillar work in developing that ambition document. And since then, since we signed that off at November boards, we've taken quite a few months actually to then do further engagement on what people thought of the initial ideas that we developed after listening to all of that feedback that we had from them. And we took a little bit extra actually because we wanted to make sure that we gave staff time to engage with it, bearing in mind it was over winter and of course over another wave of the pandemic. So we wanted to make sure people had got a lot of opportunities to engage. We've also talked a lot to some of our ICS partners, our integrated care partners across the county. You can see that there. We've talked to our other organisations, we've talked to GPs, we've talked to our community services and our mental health services, And we've been talking to our unitaries as well about our thoughts and ideas, and got lots of feedback from them. So over 600 of our staff, and you can see there that the breadth of people that came to our engagement events, over 600 came, and we've got a large spreadsheet with over 500 lines of individual people's feedback on their concerns, their opportunities, how they wanted to engage, which has been really positive, and we're keeping that. But we've also had, just before I move on actually, we've also had some wide public engagement events that got publicised in the local press through our Facebook and our social media. And we've had a public survey that has been out, and we've had lots of members of the public contribute as well. So lots of really, really good thoughts and ideas, and they've coalesced really, a lot of the thoughts coalesced around a few key themes. And that's set out in this slide in your pack. And I'll take you through some of the detail of the more intensive ones that people have fed back, and what we've done about that. But just to make assure board that we have listened to every single line of feedback, and we have been very grateful for absolutely everybody that has taken the time to contribute. So in terms of centres of excellence, lots of enthusiasm about the centres of excellence, and that they represent a really good opportunity to further grow our research and our development in those areas, further grow our specialist care in those areas, and really make them beacons for attracting talent to come and work in our county. So lots of enthusiasm for that. I think where people started to get perhaps at least initially slightly confused around the centres of excellence was about what we really meant by them. And that was helpful feedback. So pretty early on, actually, in the first couple of weeks, we clarified, and we've strengthened that a lot in the document, but also in the way we've been explaining it to our staff and to our public, and that these centres of excellence are group centres of excellence. They are for the county. They're for all of Northamptonshire patients and all of our group staff to work in. And in particular, one that came out quite loudly was the robotics. So we've now got, of course, the robot at Northampton, and Faye mentioned that earlier, but that's an opportunity for all patients and all staff to make the use of those specialist pieces of equipment. And we'll soon be having the cardiac MRI at the Kettering site too. So that was really helpful in terms of that initial feedback, because we've been able to really strengthen our messaging on that and make sure that that's really clear. In terms of single team, again, people very keen to work together across the group, and the benefits that people can see in that for their own development, but also for patients. But of course, understandably, a lot of people came back and said, well, what does that really mean in terms of, are you going to, do you think that we'll be changing where services are provided, or where I as an individual might go to work every day? And so again, we've been a lot clearer, and that's one of the key differences in the document about how we will start to approach some of those conversations. So if there is a case for change, moving services will always only be done if it's in the best interest of patients. And where our clinicians are coming forward and saying that they think it would be in the best interest of patients, if, for example, if there's clinical evidence, national clinical evidence that we know co-locating services really drives up outcomes for patients, or indeed if we've got unsustainable services at one site or another and patients are getting inequitable access, and by coalescing services together, we know that we can strengthen that and make sure all of our patients are getting access to our good services. Or indeed, because we think services can clinically be provided closer to patients' homes and community settings, then absolutely, if that's what we think, then we will start to talk much more detail with our staff and with our patients who use and work in those services to understand that properly. And we've made that a lot clearer in our document now. Again, lots of positivity about integration with the community, and our clinical staff in particular really saw that as an opportunity to transform patient pathways, to make it seamless for our patients when they're accessing different services in a pathway of care. So lots of enthusiasm on that. And so we've strengthened our strategy document with some more detail about how we might do that, and particularly some more detail around the elective collaborative that I mentioned earlier, and our plans for the next year as to how we can really transform elective care by integrating with community partners. One of the things that was really quite interesting, actually, that some of our staff raised, is that the document was quite quiet on mental health. We had mentioned the mental health collaborative, but what we hadn't really addressed or mentioned in there was how we're going to support the mental health and wellbeing, improve that support of patients who are accessing our acute services. So again, you'll see if you read the detail of the document that as a common theme throughout is now how we are going to support that. So as we start to transform pathways of care, we will do so absolutely with a view as to how we can improve the support of those that are suffering from anxiety or other mental health problems. So another area where the document was quite quiet, and we have now improved it and got a whole new dedicated section, is on our ambitions to be a net zero carbon. So both of our organisations, Northampton and Kettering, have got green strategies in place, as has the ICS now. But our document was quite quiet actually about how we need to transform pathways with a view to being net zero carbon, the view to making sure that we're using our digital enablers to allow patients to access care from home where possible and stop them having to drive into site. So again, we've added a new section in that, and that's quite different from where our ambition document was. Overwhelming support for our university status and the opportunities that can bring. So again, we've strengthened that section in the document and added in a lot more detail about our plans around our group academic strategy and our growing our research and our development. And I think probably final slide from me. So I think I've talked about ring fencing elective capacity. I think that a lot of our clinicians bought into it, agreed that the clinical ambition and our ambitions in it were the right ones. Where they challenged back was to say, and how are we going to do it? How are we going to resource the implementation? And to implement, we need a really strong digital capability across the group, and we need an estate strategy that can help support implementing this strategy. So we recognised that as we went through the ambition document itself, and we've set out more clearly some of our plans across the group for our digital strategy, for example, and for now creating a group estate strategy that responds to the clinical strategy. We'll be doing that over the course of the next few months and implementing some of that. So we've been quite clear on that, and we are just working out at the moment our resourcing plan for how we might implement the strategy, and in particular how that resourcing plan then links to our integrated care system and the clinical work that we want to do with our system partners, because they are one and the same thing. So we are working on that resource plan at the moment, but absolutely there is a commitment that we need to invest in this to resource the implementation. So I think those are the key areas where the document has changed following the feedback. I think before I hand back to Rabia, the other key areas that have developed in the document is further detail, I've already mentioned, on our plans for elective, but also further detail on our cardiology strategy. And Debbie mentioned in her update earlier the really successful cardiology strategy away day that we had recently. So there is a lot more detail now that we're starting to form on cardiology, and that has been included in the document, but that is a work in progress that will continue to be developed. We will continue to get more detail on that. And certainly as we do that, we will continue to absolutely engage with all of our staff and our patients and service users in cardiology and any of those associated services. With our Cancer Centre of Excellence, we are planning the Cancer Centre of Excellence strategy launch date on the 8th of July. Invites for our clinical teams are going out today for that. So we haven't got as much detail on our clinical strategy for the Cancer Centre of Excellence in this document, because we haven't as yet had that day, and we've wanted to take more time with our cancer clinicians to talk about the Centre of Excellence, and we've done that over the course of the last few months. So we're now ready to launch that day, and we look forward to that on the 8th of July. But back to you, Rabia.
Thank you, Polly. If we can go on to the next slide, and I think we've covered most of it, so I'm not going to take much time here, but what I wanted to say is that I'm sure everyone will appreciate that a lot of work has gone into getting the strategy to where it is today in the last 6 months. One thing which hasn't changed is the 4 key domains, which outlined our aim for delivering collaboration and achieving our commitment to excellence. And we absolutely believe that moving forward, integration with the entire system is the only way. And not only for prevention, but also for elective and emergency care improvement within the organization, within both the organizations. So as we heard earlier on, I think Simon, you made a comment to virtual wards, and that would be an example how we would want to work more collaboratively. Debbie made a reference to integration that is required absolutely with discharge processes, and Home for Jubilee event is already an example of collaboration, which Faye mentioned, that we've got whole team working with us. So that absolutely it will be necessary, and will be the key. Center of Excellence is for the county we are developing, just capitalizing on our strengths, which we have as a plenty, but also tapping on the opportunities and build on them. So I'm not going to go into the detail of any of them. Our starting point, as Polly mentioned, cardiology and Cancer Center of Excellence for the entire county, served by the specialists in both the hospitals for the patients across the whole of Northamptonshire, is what we would aim to get on with. And cardiology strategy is part of our main strategy today, and I'm not going to go into the detail of that. Cancer, certainly Matt is with us, so I'm sure he'll like to add some things towards the end. But again, we did hear that we've already got robotic surgery up and running there into 2 specialities, urology and colorectal. But urology, we've already identified how we ourselves, working as a group, will be addressing our very own problem of long waiting lists for robotic surgery, and hopefully by late in summer we'll be able to help with that. And again, with anything we plan, we need protected elective capacity and for delivering any sort of excellence, and that is really important. I think I'm just going to in the end, when mentioning, I'm going to use a phrase which Edmund used. I absolutely loved it, about university hospital status. Edmund, you said foundation of excellence, and I think that's what a university hospital status is. It gives us that foundation of excellence. We are already seeing the positive impact of our university hospital status on our recruitment. We've already appointed first of our academic associate professors, and we've got 9 other waiting interviews for professor and associate professor post. We've got increased number of medical students coming in, and we've also increased the academic opportunities for all our staff group. So I think absolutely really exciting future our collaboration offers, which is recognized by our all our staff as well. Polly, if we move on to the next slide, which gives us what we are planning to do for next couple of months in terms of carrying on with our engagement with our staff, providing the feedback to them, and going back to them and saying actually how what they have said is helped shape our strategy moving forward, but also carrying on with our engagement with our public and patients, including Health Watch and Northamptonshire Curers Group, and also individual patients in specific specialities to join the focused groups as well, and also continue our engagement sessions with our partners, and absolutely vital engagement with the Health and Wellbeing Board and Overview and Scrutiny Committee again later in summer as planned. The last slide gives us the timeline of what most of it is talked about. The only thing we didn't touch, I want to just mention briefly, is there are certain services which we feel are not sustainable or fragile in their current shape. And we will be looking at them, trying to see how we can strengthen them along with all the work we've highlighted, and while working on our centers of excellence. And I'm going to stop there and bring Matt in to add any reflections. Matt?
Well, yeah, thank you, Polly. Also, very little to add to that comprehensive and excellent overview from Polly and Rabia, who have now merged into one. So only really just to say that from my perspective, one of the things that's particularly exciting about this excellent strategy, which I commend to the board, is that it's not a dusty document gathering dust on a shelf somewhere. It's already, what a good strategy is. It's a living, breathing thing that is already making a difference to the patients of our county. Be that those cancer patients having their surgery earlier and without the need to travel than they would have done previously using the robot. Or those cardiology patients will have access to state-of-the-art diagnostics without having to travel out of area very soon. Or the record number of patients who've been able to participate in research studies and having access to cutting-edge treatments today and tomorrow. We're already on that, and the fantastic increase in number of candidates for consultant posts at our hospitals and candidates for the academic professorships and associate professorships is a really exciting future, which I'm looking forward to supporting across the group. Thank you.
Okay, are we done? Yeah, thank you very much indeed, everybody. We've had a lot of conversation about this in the past. It's two things occur to me really. One is that the conference on the 8th of July, which Sir Mike Richards is coming to as former National Cancer Czar for the NHS and now chair of several national committees in this. I've known Mike a long time, and I'm sure he'll add a huge amount to that day and run the clinical conference. I made the point in the Northampton board yesterday, but non-execs are of course invited to that, and KGH non-execs, because this is a centre of excellence across the county, would also of course be invited to that day if you can make it. I think it will be very interesting. The other thought that occurs to me is we should remind ourselves occasionally that the whole purpose of coming together as a collaboration was to improve our clinical services. It wasn't to do a whole load of other things in back offices and so on. Not that those things won't happen, but that was not the purpose. So now we're moving to agreement on this clinical strategy, having consulted on it. We're now into specifics and delivery mode. So guys, there you go, challenge laid. Any other comments or questions before we move on? No, nothing at all. Okay, thank you very much. You can take it that that's approved. I'm sorry, I can't stop my phone ringing. There's nothing I can do about it. You can take that as read and we'll move on, but it's a continuation of the Polly Grimmick show with an infrastructure work on hospital improvement programme scheme to do just an update on the energy centre and the enabling works that go with that. Thank you very much. Richard, you can take it that this strategy was approved. And Polly, over to you again.
Thank you very much, Chair. So yeah, as you say, this is just here for an update on the progress that we've been making over the last year in rebuilding the Kettering Hospital site. So in terms of our main scheme, we spent the last year doing lots of exciting work, working with a really wide group of our clinical staff and our patient groups on doing some more of the detailed design of some of the first clinical buildings that we're planning to have on the site. So that those buildings, and that includes a new emergency department, urgent care floors, inpatient wards and theatres, and it also includes a new main entrance to the hospital, and new access routes and parking onto the site. And you can see an artist's impression of what we think that might look like in the slide. So my thanks to all of the patients and the staff that have been involved with that. So we've got some really good designs now that really meet the clinical needs of our staff and our patients, both now and in the future. They're fully designed with digital technologies within them and with net zero carbon embedded in their design. So it really does take us on into a modern healthcare facility. In terms of where we are with that, we are due to and on track to submit our outline business case for that scheme at the end of July. And we then look forward to working on our full business case later this year in partnership with the National Hospital Programme team. But before we do that, we know that we also need to progress with a series of enabling works to get the site ready for building. That includes new car parks, that include, or different car parks, that includes demolishing certain buildings. But the key one that, the key priority really is about replacing and upgrading the way we heat and power the site and our buildings on it at the moment. And I've set out some of the risks and the issues that we have that are not insignificant with our current solution to heating and power. Insofar as we have a reliance on temporary boilers, they're over 10 years old now. They aren't of the most efficient boilers, and we incur annual rental charges on those. You can see a picture of just how lovely they look and how attractive they look in your slide deck. But so we know we want to replace them with a full energy centre. We've also got reliance on backup generators that are over 20 years old. They aren't functioning. We just have a different healthcare site than we had 20 years ago. So whilst they do provide for essential areas, it's not in the way you would design a modern backup generator system. And so a reliance on them is something that we need to upgrade and fairly quickly. We have also got a very old, over 50 years old, steam distribution network that runs throughout the site. It is, to say it's creaking is an understatement. We are taking very regular maintenance and repairs of faults in that steam system. And because of the way steam distribution networks work, you have to shut down large areas of the site to de-steam it, to do that maintenance work. So we're ending up with clinical areas of the site without hot water and without heating for significant periods of time, actually, at a time regularly, because of the maintenance and the upgrade work that we need to do on that very old system. And the final one is the electrics, actually. Again, our site has grown and our activity has grown throughout the years, as has every hospital. So we are now at the maximum of the amount of electricity we can physically take onto the site. And we certainly aren't in a position that we'd be able to build any new buildings without upgrading all of that electricity supply and really bolstering it up so we can take a lot more electricity into the site, not least because it's that electricity that will power our new energy centre. So we do have a plan. We are submitting some business cases in the coming month or two on both the electricity and the energy centre to replace all of that. But we are going to require an early release of our enabling funds from the new hospital programme team to enable us to progress with mitigating and managing that risk and putting those solutions in place. And we're going to need that quite quickly. So we are working with the national team. They are aware of that. They are aware of the risks that we're carrying on our site. And we do have, just to reassure, we do have a tight regime of maintenance and testing of all of that across the site to manage and mitigate against the risk. But of course, that's unsustainable in the longer term. And just to be clear, we will not be able to progress with any building of our new site without undertaking that energy centre work. So that's the key thing, Chair, that we really need to progress with promptly in terms of first stages in rebuilding our hospital. But happy to take any questions on that. I guess the only other thing I'll quickly add, sorry, I forgot, all of that work will make a significant contribution to our net zero carbon ambitions as well. The energy centre itself will reduce our carbon footprint by 58%. So some real opportunities around that as well.
Thank you, Polly. It's a good update. And I think everybody knows our governors as well are very keen in Kettering for us to sort out the green agenda, and keen for them to set up a particular group to be a pressure group for that, a ginger group. So the whole safety and security of the power system, of the heating system on the site, the hot water system, is crucial, but so is the green agenda to everybody. Simon, your hand is up.
Thanks, Alan. Firstly, thanks for the update, Polly, and I just want to also record the fact here that our 3 local MPs have been enthusiastically supporting us in our endeavours to get this capital released to do the work that we need to do. Nonetheless, I have to say it is disappointing that we have been mired in national hospital programme bureaucracy now for over a year. I started to have these conversations at both political and senior operational level within the programme, and we have still yet to receive a confirming response that the money has been released. And so I wanted to take the opportunity of meeting in public to express my frustration and concern at these delays. Our local MP, Philip Hollowbone, has secured an upcoming meeting with the Secretary of State, at which we will again be pressing for the same thing that we have now been pressing for on and off the last 18 months, and I hope for a better outcome. But I cannot also overstate the risks that we carry and will continue to carry as we head towards winter if we are unable to start planning for a different outcome to the one that we have at the moment. I also want to say this is in no way reflective of the endeavours of Polly and her team, who have been dutiful beyond measure. It is, I have to say, a problem entirely outside our control.
Yes, I think we'd all agree with that, Simon. It is a deeply frustrating process. We know that the government finances are stressed. We know that there are lots of other issues, but it is a deeply frustrating process when you lay out plans and raise expectations and then cannot deliver them. Okay. Well, I'm tempted to say you've missed out on your coffee break because we're 10 minutes late. But all things considered, 10-minute break now, please. Back at 11:50. That's a 9-minute coffee break, actually. 11:50, please. Thank you. And there we go, 11:50. You want to take the sign down, please, Karen? Thank you very much. You should all be back. Staff survey response. Paula, are you there? Yes, you are. Jolly good. Well, your boss, Mark, gave a very succinct version of this yesterday at the NGH board, so no pressure at all, but over you go. A quick review of the staff survey. We do take this incredibly seriously. We have had a lot of conversations about this in our board away day, and both trusts are thinking very carefully about this. I know Northampton talked about it yesterday, and Kettering can obviously talk about it today. But this is really a brief update to put the results into the public domain. Paula, over to you.
Thank you. Yes, you're right. This is something we have talked about a lot, but just to cover this today, 3 key points really to draw out of the paper that Mark has shared. So firstly, we were very disappointed with the response rate this year in terms of the number of people who'd engaged with the survey, down significantly from last year, 58% down to 44%. So we have absolutely set ourselves a target for this coming year's survey to achieve a 60% engagement rate. And we've already started to think about how we're going to go about that. But not only did less people engage, but the scores overall were not as positive as they have been in the past. Kettering traditionally has tracked at this sort of average level of scores across comparable trusts, and this year we dipped below that. So something of concern for us. We know when the survey was carried out last autumn, that obviously we'd started winter early. It's a very difficult time. And we know also that there have been significant amount of change and new things going on in our organisation. So the survey was done against a backdrop of some really quite challenging times and things of new things and things of concern for staff. So what did the survey tell us? It told us four key areas that we need to focus on: teamwork, reward and recognition, respect, and leadership and management. And those were 4 very strong themes that came out of our survey, but also very similar themes to our colleagues over at NGH. So what have we been doing? We had a group away day where we came together and we really looked at what the surveys had told us, made sure we understood that, and we shared the analysis and what we'd done in each organisation since the survey had come out. And then we started to understand what we might do next. We had a visiting speaker from a trust that had been along a similar journey of improvement in their staff experience. And we really took the time to consider what we should do. And as a result of that, we've committed to a significant culture change programme over the next 2 or 3 years to really focus on changing behaviours and staff experience within our organisation. We also, as an organisation at Kettering, had a HMT, our hospital management team, away day. So we took everyone from our executive and our senior leadership teams across the trust off-site for a day, again, to make sure that we had the opportunity to reflect on what the survey had told us and to focus on what we thought were the important things and come up with actions that we thought we should focus on across the next year. And in developing those actions, we were able to draw upon other insight that we'd gained by a number of listening events that we've been running across Kettering over the past few weeks. We had a big campaign where managers from all over the organisation went out and listened to different staff groups. And we also did some corporate things. So we have our Let's Talk every Wednesday. We devoted a whole Let's Talk session to staff experience one week. Really high engagement from staff, lots of ideas shared. So using all of that information, we have put together our own internal action plan focused around our dedicated to excellence values, and we'll be working through those things over coming weeks and months. And as a group, we've also started to think about next steps and our priorities in this area. So just to commend to the board, we've heard a lot of positive things this morning about the future of Kettering in terms of our clinical strategy, in terms of our new build project, our aspirations for excellence. And we want to make sure that not only are we providing excellent care for our patients, but the experience of our staff is as good as it can be as well. And we will be pushing forward with our plans to make sure that is the case. Thank you.
Thank you very much, Paula. That's a good, crisp update. Any comments on anything there at all? As I say, we have talked about this a great deal and will talk about it again a great deal. I think you're absolutely right. Of course, the key is to get a high response rate for the for this, and then at least we are even more confident in the views of our staff. Debbie.
Yeah, thanks, Chair. Thanks for that update, Paula. So I just wanted to comment really and say, whilst it's absolutely disappointing, what's really important here is that we listen to what our staff are saying to us and start to act on that. Now, of course, we're not going to be able to act on everything that they say, but we will be taking a few key actions this year. One of those is to make sure that we have a staff restaurant in place that provides some hot food for our staff, both in and out of hours. So just wanted to make that point, but also the fact that as an executive team, we are all behind making sure that Kettering is the best place to work and be treated. So we'll be focusing constantly on our plans. Thank you.
Yes. Okay. Yeah, it's long been a wish of ours to have sorted out the staff restaurant. It is the most extraordinary story about why we haven't got one, actually, but it's long been a wish of ours to sort it out. I remember when Alice and Lisa Janoff first became non-execs and they attended an induction session. One of their first comments to me was, "Got to do something about the food for the staff." It's taken us quite a while. It's taken us all quite a while. So that's to be commended, to say the least. Yes, good stuff, good report. We won't be able to do everything our staff want us to do. Of course we won't. We're under a lot of pressure to balance everything. But there is an old adage in the health service that if you look after staff, the staff will look after the patients. And that's pretty much what the system is based on. So thank you for that, guys. Okay, I haven't got Dr. Bilalika on my screen. Do we know if he's here?
He's not. We're just working on getting him to join, Alan.
You what? I'm reluctant to move on to the Ockenden report because it's quite a lengthy slot, that one. Are you advising me to just wait for a minute or so?
Mr. May's just been in touch with him, so hopefully he'll be here in a minute. Yeah, he's nodding, so we're just hoping he'll join now. We could cover the Falls report if you wanted, Alan. That's scheduled for 10 minutes.
Good idea. Take me to the Falls report. Fiona.
Thank you, Chair. So I would like to update the board on our current position in regards to our Care Quality Commission recent report. The board and the public will be aware that the Care Quality Commission, CQC, made an unannounced visit in May 2021. And their focus was to look at the care that we provided for our patients that had fallen in the organisation and may have sustained harm. So the review that was undertaken through the inspections identified a number of significant concerns and a number of areas that we needed to improve upon. Since May, the organisation has implemented a substantial improvement programme led by our hospital chief exec and the director of nursing at the time, Leanne, to ensure that a multi-professional and multidisciplinary review of our care associated with patients that had fallen in the hospital was undertaken and implemented a detailed action plan to improve the ongoing care of patients who may fall, but more importantly, to reduce the risk of a patient falling. That work has been ongoing since May of last year, and I'm very pleased to say that when the CQC, the Care Quality Commission, made a further unannounced visit in March of this year, they found significant improvements. They recognised the extensive amount of work that had not only taken place, but had been sustained over the months through the programme of improvement, to the point that they were satisfied through their informal feedback and their formal feedback and the final report that is within the pack and the public domain, demonstrating that they were able to remove the original warning notice that had been placed on the organisation. So at that point, I'm more than happy to take any questions, Alan.
Thank you very much, Fiona. Are there any questions on the Falls? Arsha, it'd be really good if you could switch your microphone off. Are there any questions? Marsha, could you switch your microphone off, your speaker off, please, for a minute? You're making it's coming across as a lot of noise. I'll be with you in a minute or two as we finish the last item. Thank you. Sorry, is there any comments on the Falls report? It's been a good report. It was quite a stinging rebuke. So Debbie first, and then Simon, please.
Yeah, thank you. Just once again wanted to say thank you to everybody that has been involved with making the changes. I'm really proud of the teams for what they've done over the last 12 months, actually. You can really start to see the difference. We are also holding a thank you event next Wednesday, and would also like to make sure that members of the board are invited to come along and say thank you to our staff. Thanks, Chair.
When is that, Debbie?
It is on Wednesday next week. I have sent out a diary invite and email to you.
Okay. Thank you. Simon.
Just to echo what Debbie said and to add, we have spoken extensively to staff about what made the difference in terms of why this has fixed it, and therefore how do we keep it going. The overwhelming message that came back was that staff felt in the driving seat of these changes, and they owned them as a consequence in a way that they felt committed to keeping them. That message came back from all the visits I did, Debbie did, and others of you have seen. I'd encourage you, as you come and visit the wards, to go particularly and visit Naisby's and see some of the work that has been done there. I'm sure Fiona would be delighted to take you round. And finally, I think to call out particularly two people who I had the privilege of meeting, working with on this issue. One, Jane Daniel, our head of nursing, who has been indefatigable in terms of her leadership of this issue, but also one of the ward sisters, Desreen, who I think has led a programme of improvement on the Naisby's that would be commendable for you to go and review for yourselves.
Thank you for that, Simon. Well, you know, non-execs are back in, visiting all sorts of departments, and I know both Fiona and Faye are very keen to take non-execs around. She drags me out at every opportunity. Well, drags the wrong word. She encourages me to come with her to something she wants to show me at every opportunity. So all of that is to be commended. It's a good bit of work, guys. Still got a bit of work to be done to finish, but it's a good bit of work. So thank you very much indeed for that. Right, Dr. Bilalika, over to you, please, for your annual Guardian of Safe Working Practices report. You're very welcome.
Yeah, hi. Good morning. So it's a fairly short presentation. I hope you can see some, I don't know if you can put, right, has it been uploaded, Richard?
Can do, just give me 1 second.
Yeah, sorry.
Right, you're off. Screen sharing has started.
Right. So this is the presentation for the annual year from April 20 to, I think looks like, yeah, I think right on the first line, I can just see a typo which shouldn't have, so apologize for it. At the beginning, there's a typo come up on page number 1. Apologies for that. So this is the report for April 21 to April 22. Essentially, there were more or less similar exceptions this year as there were last year. Richard, next slide, please, if you don't mind. As there were last year, about 104 in this year. I think we jumped one ahead, but between, I'll just read it out. Between April to August of last year, there were only 9 exceptions, and they seem to have tripled every 4 monthly. So 9 in the first 4 months, 26 in the next 4 months, and in the last 4 months, they've gone up quite significantly. And I suspect this is down to the return to working post-COVID and the pressures the whole organization and all staff are. There is quite of increase. The pattern hasn't changed. It very much remains work-related. Again, staffing gaps and absences. Quite noticeable in the last 1 year was that there have been no exceptions from A&E reported in the whole of last year, which is a bit of a surprise, and that might be down to the changed working practices in A&E. Increase, particularly, again, urology had gone off the radar the year before. It's made a reappearance lately, and more worryingly, obs and gynae, which never had been on the radar, has now started reporting, and pediatrics is a problem. So there's been an increase in the last quarter, mainly from urology, pediatrics, and obstetrics gynecology. Next slide, please. As I mentioned earlier, this is more likely to be due to continued staffing pressures. Educational exceptions have been reported by the Foundation Year 1 doctors, and this is about their quite often this is about their self-development learning time. Again, the time that had been lost previously, they were given 2 hours on the trot. And because they couldn't really take 2 hours on the trot, the 1 hour became lost, and that's led to quite a few exceptions. These are down to the DME to address. I think these are being addressed as we speak. There were issues in orthopedics, particularly more or less from the last 6 months, where people weren't getting the time they were meant to get off. So where there was time they were rostered off, they were having to come in. And it became apparent and has been addressed by making compensatory payments to the doctors who were affected. These were all middle grade doctors who were affected, and HR to make sure that such instances don't occur in the future. So that was quite a difficult one to sort out. Urology, again, has cropped up, which had, after the employment of nurse practitioners, the support on the ward had improved. I think over the last few months particularly, the issue is twofold. One is the daytime support on the ward when there are people on sick leave or absences. And then the other issue is that the urology trainees were doing their on-calls, do their on-calls as part of the surgical rota. And therefore, these exceptions reported from urology, but really relating to surgery, especially on a Friday and on a weekend. So what we've done is we have proposed a weekend augmented cover for surgery, which was possible within modifying the rota template, and it's now with the surgeons to consider that whether they want to implement that rota change without any significant change in resources required for that. Next slide, please. So in obs and gynae, exceptions reported have been both work-related and educational. Educational related mainly to not being able to leave the ward to get the self-development learning time, and work-related again mainly related to rota gaps at the SHO level. So the foundation year doctors having to pick up that work. Pediatrics. Pediatrics is beginning to show up, particularly in the last quarter. Pediatrics is going to be a challenge, it's been a challenge this year from a staffing perspective. I would expect that this challenge continues over the coming year and perhaps years. That is because nationally there are very, very few middle grade doctors. So while the posts are there to staff the rota, so the rota template is appropriate, the number of doctors required to staff the rota are almost impossible to recruit. That mainly applies to middle grade doctors, and the ones that are recruited often take some time to bed in. So I think it is going to be, unless patterns of working are explored by the trust, I can't see any immediate short-term solution myself. Moving forward, next slide, please. So essentially, the locally employed doctors, I think we have a number of locally employed doctors coming up to almost half our workforce, and their numbers are going to increase over the coming years. So the junior doctors contract has two aspects to it. One is the educational aspect, and the second is the hours aspect, the contractual hours aspect. Now, the contract as it is applies to the doctors in training. However, from a trust perspective, it would make much more sense that the locally employed doctors will have the same level of both education and hours related protection. You might remember that this has been something that I have put in more or less every year as a recommendation for the trust to consider. I think as we speak, the medical director is very keen to take this further. So discussions are in progress to evolve a mechanism for implementation, because for these group of doctors, undoubtedly that will lead to some new pressures within the system identified, but the time and effort step put in that would certainly stand the trust in good stead over the coming years. My personal view is that this should apply not just to the hours bit of the locally employed doctors contract, but also for their educational aspects as well. This is because most of these doctors don't come in to be employed as locally employed doctors. They come in with a view to go into training. So we must make sure that they learn and they earn at the same time. So I would suggest that the contract should not just pick and choose what the trust wants to apply, but if you're going to apply it, we should do it whole scale. So that is in summary the report for last year. I just wanted to thank the trust for its support, the medical director, the HR, and everybody in the trust for their support. I have been in this role for a few years. I will be stepping down later this month.
Thank you very much, Harsha.
Thank you.
Very good report as ever. And before everybody else jumps in, I'll just thank you on behalf of the board for all the work you've done over the last 6 years. You've dutifully come along to the board every year and told us about what's going on. Faye and then Rabia, please.
Thank you, Chair. Just a question really in terms of the A&E reduction in exceptions. So really good to see, but just wondering if there's any intel around that, because it's great that they've had less. They've also had quite a bit of investment during COVID, so I'd be really keen to understand what's happened there.
I wish I could give you a very good answer to that. I suspect it's all those things. So the one aspect which doesn't come up all this is the people actually working there. So quite often you find that there's a variation depending on staff changes. So there's one aspect that's a human aspect there. But I suspect the real reason is the investment that's gone into A&E, and also again down to the new patterns of working where specialties are picking up bits of work directly. So I suppose the stress factors and other bits are perhaps a bit better than they were. So my problem is that I get to hear if there's a problem. If there is no problem, then I don't have any real understanding why there's no problem.
Thank you.
Okay, Rabia and then Lisa, please.
That's probably where I come in, Harsha. When there is no problem, I go there and find out what they are doing, what others can do. So I can certainly probably at least give my opinion or my observation on Faye's question as well. But before that, there were a couple of things I wanted to say, Harsha. First of all, it is like Chair said, wanted to thank you for all your support as Guardian of Safe Working over the years. We've been working quite closely over the last few months, and it was just great working with you on that as well. One of the things I just wanted to provide assurance to the board with regards to pediatric staffing it. It is something which I have actually reached out to our regional network, and it was quite a useful discussion. And recently we've had a review of perinatal regional network review, and that's where it came up as well. And one of the solution might lie in group working, and because there is a shortage of advanced care practitioner, to have group posts, because the problem lies actually across everywhere. So that was quite good. And we also are looking at physician associates, which we in Kettering train physician associates, about 40 of them every year. So we'll be using them, and those are actually more permanent pool of staff that can help fight not only the care delivery, but also the training side of things. But one of the things which I think Dr. Belorica has mentioned is absolutely I'm committed to is making it fair across all the non-consultant grade or junior doctors, is the report. And traditionally with contract, we only covered the training grade doctors, which is just 50% of our junior doctors. So absolutely looking at how we can improve locally employed doctors' experience in education and training. We in Kettering are one of the best for offering appraisals to LEDs or locally employed doctors, which is great, but I just want to replicate that into their experience in education and training as well. So we've appointed 3 LED leads across the trust, and which will be supporting our locally employed doctors and trying to bring it all together to offer the same facilities and support and training to them as well.
Thank you. Lisa.
Yeah, thank you. And look, Rabia, you addressed one of my specifics there in terms of paediatrics and the response to it. But if I step back, I suppose overall my concern, if I had one with the report, is there seems to be great clarity in terms of the areas and why, but less clarity in my mind in terms of what we're going to do about it and how we move forward. And Rabia, your specifics about paediatrics was one of my key areas of concern, but I think it was just generally the how do we assure that we're going to use the insight from this to make a difference going forward?
Do you want me to come in on that, Chair?
Yes, please.
Yeah, certainly. So at least all the queries raised or concerns raised in that report have been addressed, but also applying it to at the organizational level, meeting with clinical leads and all the consultants too, because I think part of it is that where we were with COVID in the last 2 years is trying to bring that mindset back to we are now, everything is back to normal. So training needs to come back to normal as well. So done quite a bit of work with our leads, as well as educational and training supervisors, trying to look at that. Absolutely, there are gaps in the rotas. And I think it's just that we do have that shortage. And I think we just need to look at how we can work differently. So what I'm currently looking at is the skill mix. So working with our advanced care practitioner or physician associates or any other skill mix that we can actually address. One of the other issues is that the expectations from the deanery and head of schools, which has come out, does not match the service demand. So working on that as well. So I think quite a lot of areas that I am currently working at with our junior doctors and our education committee and our clinical leads.
Thank you. Thank you. Simon.
Thanks, Alan. It's a good challenge, Lisa. So firstly, just to add my thanks to you, Harsha, for all the work that you've done since 2016.
Thank you.
It's often the people who serve in the quiet, ongoing roles over long periods of time who make the incremental difference. And you've been a quiet and patient servant in the cause of what you've done. So thank you from me too. Lisa, look, I suggest that what we do is to deal with the Harsha's report, and perhaps this is the best way we can say goodbye to Harsha indeed in this role, is that we ask the People Committee to pick this up and specifically come back on the recommendations, maybe starting with paediatrics. I know Rabia has described some of these issues. I'd also encourage, I've got my own views about what's working well. I think we've had, for example, long-term stable leadership now in the urgent emergency care department, which I think has helped and made a difference. So I'd encourage the People Committee, as you were representing it today, perhaps to pick up some of those issues specifically and take the report back into your consideration.
Okay, thank you very much, everybody. We all know the pressures and the conflicting pressures of service demands, and particularly trying to make the discharge process happen, but also the ED work. But in the end of the day, if you don't provide a good learning environment for your junior doctors, then the message goes out quite quickly. This is not a good place to be, and the problem of covering the workload gets worse. So we're very, very committed to ensuring that we meet their absolutely legitimate educational requirements and aspirations. And I'm sure the People Committee will take it forward. And it's a pretty good last thing for you to be responsible for, Harsha. So again, thank you very much indeed for your work.
Thank you very much, and can I thank everyone for their nice words. Thank you so much. Thank you.
Thank you. Right, we're moving on now to the Ockenden final report. You'll see we're joined by Fiona Barnes, Deputy Director, sorry, Fiona, you see, not joined, you see Fiona's going to do this paper, but Kim Ackley's here, Deputy Director of Midwifery, who has just disappeared from my, no, there she is. And we're also joined by Adiba Nishtar, who's the Clinical Director for O&G, to take us through this. I have some comments from Dr. Llewellyn, which are very supportive to this, which I know Fiona has a copy of as well, and she may want to refer to them. But over to you guys to take us through the Ockenden compliance report.
Thank you, Chair. So it's important that the board has an update of our position as an organisation in regards to the work that Donna Ockenden has undertaken across the country, in particular focusing on Telford and Shrewsbury. So at this point, I'm going to hand over to Kim, who's our Head of Midwifery, and then I will pick up at the end if that's okay. Thank you, Kim.
Thank you, Fiona. Hello, everyone, and thank you for inviting me to share the Ockenden report. So we've recently had the final Ockenden report published, but I just wanted to remind you of where it started and why we have an Ockenden report at all. And it was initiated following two families' concerns around their outcome of care and their babies' deaths at hospitals in Telford and Shrewsbury. And the Secretary of State asked Donna Ockenden and her team of experts to go into the trusts and to review maternity services. And what started out as a review of 23 cases quickly escalated. And at the end, they were looking at 1,500 cases between the year 2000 and 2019. So that's just a little bit of a background, just a reminder, and then just to update you on where we are with the interim Ockenden report. So due to the severity of the concerns that the investigators recognised almost immediately, we had an interim Ockenden report, which I'm sure you'll all be familiar with, and that was published in December 2020. And with that, we had 7 immediate and essential actions that we needed to address. And I'm pleased to say that last month we submitted our final position as a trust against these 7 IEAs, and they were published by NHSE last week, and they demonstrated that we had no areas of non-compliance. So that gives us a good start to then look at the final Ockenden report, which was published on the 30th of March. For those of you that have read the report, I'm sure you'll agree with me, it's a stark and sobering read, and it is more lengthy and the asks are bigger from this report. So we've now been given 15 IEAs, or immediate and essential actions, with 92 actions sitting below them. And they sit underneath 4 headings: safe staffing, a well-trained workforce, learning from incidents, and listening to families. I think I should say at this point that we've had absolutely no national or regional ask for a submission on our position against these IEAs. But I felt, Fiona and I felt as I was coming here with the Ockenden report, then it would make sense to do an initial benchmark against those 92 points, and you'll find that is in your papers. And it is very much an initial self-assessment, and it is very much a self-assessment that I anticipate will change. We've had no guidance yet from NHSE on the essential criteria or how we might be able to assure ourselves that we're green. So it's very much our initial gut feeling as an MDT, our neonatal colleagues, the obstetricians and anaesthetists have all been involved in this benchmarking. And this is where we sit at the moment, but I just want to say that is likely to change. And you'll see, if you've managed to have a look at the spreadsheet, that we've identified 2 areas of red only out of the 92. And both of these are beyond our control. One is around centralised CTG monitoring, which is to be mandated in all trusts. However, despite being signed off, it is recognised that there's further national research needed into this, because there's been good evidence to suggest that's not safe. So we're awaiting some further guidance on that before we press the button, as it were. But actually what we're doing in the background is making sure that if we are given the green light and told to go ahead, that we can facilitate that. We've just had a digital upgrade, and our CTGs are now, we're assured that it should be fairly easy to do, should we be required to. And the second red was around a bespoke training module for labour ward coordinators. Again, we have been told to not do anything knee-jerk, to wait, and there'll be, again, national guidance, because clearly the module will have to meet certain criteria. But we've also had conversations with our university, the University of Northampton, just to sort of put feelers out to see whether they would be interested in providing an accredited module, and they absolutely are. So we're just doing some little bits of groundwork, but are waiting for work stream and national advice around content and resourcing. In addition to those 2 reds, we had 14 ambers, and we've RAG rated them amber because although we're not fully compliant, we can demonstrate really good mitigation. And just one example is that the Ockenden IEA say that no newly qualified or a newly qualified midwife should remain within the unit for 12 months. We've actually got 2 newly qualified midwives out in the community at the moment, but they work in a continuity team, and the way they work means that they do at least 1 12-hour shift per week on delivery suite, so they're getting their skills, which is what Ockenden is asking for. So we're very confident that that we are giving them a good experience, and we're mitigating the risk against the Ockenden recommendation. So, in a nutshell, around these recommendations, NHSE has been very clear that they recognise there is a need for more evidence and funding and further resources to support us implementing them, and have just advised us to approach it with an evidence and risk-based assessment, and that's exactly what we're doing. We're assessing our risk, logging risks on the risk register as we identify them, and putting plans in place to implement where we can. And I think it's also important to say that one of the things that the report does ask is that this report, Ockenden, is brought through the trust board, and that the whole trust and system learns from it. There's lots of wide learning in there. It's not just about maternity services. Just the additional thing that came on the back of Ockenden was under the pillar of safe staffing. All trusts were asked to review their position around continuity of carer, and I won't go into it in any detail, but essentially the national ambition is that all women will be offered continuity of carer as a default model of care by 2023. And we currently at Kettering have 2 continuity of carer teams. These teams need much greater resource than traditional community midwifery, and given the midwifery staffing crisis across the country, trusts were asked to review their continuity position and given 3 options: either if they were absolutely assured of safe staffing and could support it to continue to roll out their continuity, or if they could support what they had at the moment but couldn't be assured of safe staff, and if they extended it, they should just cease further rollout, or they should stand down all continuity teams if they were not assured of safe staffing. We've done a very thorough risk assessment, which I've put in SBAR format for you to review. And we have decided that because our 2 continuity teams target only BAME and women as their areas of deprivation, we're very assured that the benefits far outweigh any risks. The actual benefit of bringing the midwives in and the shifts we'd gain is very small, and the risks for these women, and for example, we know BAME women are 5 times more likely to have adverse outcomes in pregnancy. We feel that we can support these continuity teams, but we will not be extending it further. The date for it to be a default model has moved back a year as well, so we're now we've got till March 2024, and that would be another risk, stepping down continuity. I don't know how we would engage the midwives again to join those continuity teams if we stepped it down, because we had to step it down during the first wave of COVID. And that is what I wanted to say. Thank you.
Thank you, Kim. So I just wanted to add to that, that within the Octon report, it looks at a number of recommendations across 4 particular areas of focus. And they are focusing on safe staffing, ensuring that our staff, our workforce is trained, and ensuring that we learn from any instances that occurs within our services, but also listening to our families and to our staff. And through the review that the team have undertaken as part of the gap analysis, we've looked at our governance processes from both a directorate perspective, a divisional perspective, and across our maternity safety champion meetings to ensure that each aspect of that, those pillars within the report and the recommendations are considered. As Kim has said, there is work that is ongoing, but we are assured through the metrics that we undertake and review, through our perinatal dashboard and through our Embrace dataset and Saving Babies' Lives, that we can demonstrate compliance with those metrics and those competencies that are required. I recognise that Adiba is here on the line as well. So if there were any questions, Chair, for either myself, Kim or Adiba, more than happy to take them from the audience.
Okay, thank you very much. We have discussed the interim Ockenden reports, and twice we've asked the question, how do we know our maternity services are safe? Emphasis on the word know, not think, not hope, not expect. No, and up to now the answers have been pretty good. This report takes us a bit further. Obviously the definition of safe is now slightly moved by the Ockenden report. I like your optimism that it's the final one, since she's now in charge. She's now chairing the Nottingham review of maternity services. I suspect there will be a further Ockenden report to flow from that. But it's a good piece of work, and the question we will be continued to ask, and we have a responsibility to continue to monitor that. Any questions or comments from anybody on the board before I go to Simon? No? Simon.
Thanks, Alan. Just to say for board colleagues, we recently received a national visit from the Chief Midwife, Jacqueline Dunkley-Brent, and her team. Rabia, Kim and I attended, amongst us, as did Fiona and Debbie and Faye, so we were well represented there. They commended us on our progress, I think it would be fair to say, and felt that we were headed in the right direction. That's not us being a moment for complacency. The challenge that they put to us was, you are in a good position, but how do you sustain it? Because at the back end of the conversations that they have started, they're now looping back round some of the maternity units that they went into very early. And so for us, the challenge is we've got to keep what we've got and continue to make it sustainable. And I just wanted to highlight that Jacqueline would have wanted me to represent that challenge to this board in particular. And for us to continue to think about that sustainability question. So I will leave you with that thought. Thank you.
Thank you, Simon. Very helpful. Adiba, do you want to say anything at all?
I apologize firstly that my camera is not working, so you can't see me, but I can see you all. So first of all, I would like to thank all our midwifery team, in particular Kim, because there's a lot of work that has gone into preparing these reports and a response to it. As Simon rightly put it, I think it's not just about making sure where we are, but ensuring that we maintain it, because that's going to be our biggest challenge. Yes, there are things that we need to look into in more depth and ensure that we deliver this service safely and continue to do so. We are already looking at different proposals of how to maintain our workforce, make sure we have retention, we don't lose people. And secondly, we need to ensure our processes are tight and safe across the board. And it's not just for maternity services, but also for gynecology, but especially maternity. So with that in mind, I think we also have this joint working with our NGH partners and ensure that we are all doing similar things, so that a woman that goes for care in Kettering and Northampton has the same experience. If we can improve on it, even better. So overall, I would thank the board, and I would thank everyone on the team to give us that support and assurance that our needs will be looked into. And we would ensure that if there is anything that is outstanding, that should be celebrated. And things that need to be worked on, we need to continue to focus on that and develop it further. So with that, I would say thank you to all the team, and I would hope that we keep on the encouragement and work together well as a team for years to come.
Thank you very much for those comments. I'm sure as we go forward, the focus will be on staffing levels across all the disciplines, the leadership training and the collaborative culture, which is pretty much what Ockenden talks about, and no doubt we'll continue to talk about once she's had a good look at Nottingham. Okay, thank you very much for your attendance, and thank you very much for the high quality report. Many thanks to all of you. Thank you. Board Assurance Framework, Richard.
Thank you, Chair. So I think there are three things I want to talk to the board about around the Board Assurance Framework. The Board of Kettering General Hospital and Northampton last year agreed on an interim approach for 21-22, whereby our group strategy dedicated to excellence has 8 underlying strategic initiatives, and we undertook a piece of work to treat those as our principal objectives, and we created a board assurance framework for the group, which has predominantly had oversight from the Collaboration Programme Committee. Alongside that, and as part of our transition, we maintained a separate board assurance framework at Northampton and a separate board assurance framework at Kettering. So what you see in your papers is the Q4 review for the group BAF and the Kettering specific BAF, which together make up the board's assurance framework. And I'm sure my executive colleagues who lead on those risks would be happy to take any questions on those. But moving forward from the approach that we've taken for the last year, both the Kettering Audit Committee and the Northampton Audit Committee have separately met and undertaken deep dives of the risks. They have come up with some really helpful recommendations around how we present strategic risk and how we can interact with it in a slightly different and hopefully better way for the year ahead. So when we come back in July, you can expect the reports to look a little bit different and hopefully to be more usable for the committees to do their work. And the second thing that we're going to do is we are going to map where the trust only risks actually form a contingent part of the group risks, because we are now absolutely firmly on track with dedicated to excellence as the single direction of travel for both organisations. So we will see some difference in the board assurance framework from July onwards at board. What's going to happen between now and then is I've already started having these conversations with executive colleagues and in the committees. We'll continue that conversation through June and July. I'll be taking a process paper to the audit committee in June to talk them through how this will work so that they can give assurance to the board that that process is robust and sound. And I'll stop there to take any comments or questions. Thank you, Chair.
Okay, thank you very much, Richard. There have been some long-standing concerns with the way the Board Assurance Framework Risk Register in NGH was put together, and part of this process is to bring those two into a fairly common alignment. But the other thing, of course, we need to do is if these risk registers and board assurance framework are correct, which we obviously expect them to be, then they must steer the investment pattern during the coming planning round. That's just common sense. If you put something in as a risk register of 20 and then decide to do nothing about it, you would clearly have some questions to answer when that failed. So it's very important that we bring these into line and that they totally inform that. And indeed, you know, I might add that as we come to the non-exec director AD on the 10th, some reference back through the planning assumptions and the intentions back into the board assurance framework would be helpful. Any comments or questions, please? Or are you happy with the changes and the process? The key issue here is the process by which we arrive at these scores. And the second key issue, of course, is what you're going to do about it. So any questions or comments at all on this? No, I don't detect any. I think we're very happy with the process at Kettering and the fact that it produces a robust, well-argued risk register that doesn't have too many things on it, which is largely the problem at NGH. Okay, lovely. Thank you very much. Annual self-certification. This is a recommendation from the Audit Committee that we approve our trust self-certification that says, look, we're entitled to continue to be a hospital. So it would be a bit silly if anybody on the board decided they didn't like this proposition. So can I take that as approval to the self-certification the Audit Committee has done? Good, thank you very much. We also have Audit Committee terms of reference, which is really to enable its alignment with NGH and reflect the committee's role in providing oversight of group activities in anticipation of a move to a board in common. And that's a necessary part of the process. We could not legitimately claim to be well led if we had not aligned, particularly the audit function and the board assurance framework as we move towards that. So, are you happy with the amendment to the terms of reference for the Audit Committee? Bum, 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 bum. Yep, good. Thank you very much. Elective Collaborative Committee. Well, you need to agree the establishment of a committee in common with NGH to provide the strategic leadership to the Elective Collaborative and approve the terms of reference and delegate authority to the chair, that's me, to confirm the appointment of Dr. Llewellyn as the chair of that committee. And there is a non-exec director representative from NGH, which will be Elena Lofteba. I can't emphasize enough how astonished most of my fellow chairs of acute trust around the country are to be told that we actually lead on the Elective Collaborative. And it's a sign of considerable trust in us, and I guess to some extent the fact that we're in a relatively small integrated care system. But nevertheless, it is a big responsibility, and it's very important that we take that responsibility seriously to act in the best interest of the system as we deliver the Elective Collaborative and not fall into any traps about the best interests of NGH or KGH, but it's the best interests of our patients as they flow through a rehab and prehab at both ends of the spectrum and the elective process in the middle, wherever that might occur. So this is a very important collaborative committee. I know a huge amount of work's gone into that work, that led by principally Polly, I think, and the clinical leadership about how this will be set up. I just want to emphasize that this will be a large, well, given there are only 4 priorities in the integrated care system, and this is one of them, this will be a large indicator of success for the ICB. So, are you happy to approve those proposals? Good, thank you very much. And finally, item 17, this is the most bizarre bit of weird bureaucracy from NHS England you can possibly imagine, but for some bizarre reason, we have to actually formally nominate Simon to represent us on the Integrated Care Board. So can I assume you are happy to do that? Good, thank you very much. Any questions from the public? I haven't received any in advance. It's the last time I looked. Richard, has there been anything since? No. Any other business at all? No. Gosh, you can't have speed up towards the end, can't we? Right, can I now ask you to pass a resolution to exclude the public and the press on the basis of the remainder of the meeting having regard to confidential nature of the business? Nods will suffice. Excellent, thank you very much. Now I have another question, because we are somewhat ahead of schedule because of that bit at the end. Do you want to bring forward the private meeting to what would effectively be 1:15 or 1:30, or is that difficult? No, want to bring it forward rather than keep the break?
Chair, can I just check that our partners that will be there